NQF team is just going to take a quick head count to see where we're at with standing committee members, and we'll begin the meeting in another minute or so. Thank you. Okay. Good morning, everyone. I'd like to welcome you all to the Spring 2022 Measure Evaluation Web Meeting of the Perinatal and Women's Health Project. My name is Tamara Funk, and I'm the director supporting this project. I'm excited to be here with you today, and I look forward to the robust discussions we will have. I want to thank you in advance for your time and participation, as I understand that it takes a significant amount of time and effort to review these measures and to prepare for today's discussions. I would also like to extend a thank you to all our measure developers for being on the call today. We also recognize the time and the effort that goes into the creation and testing and submission of a measure, and we want to highlight those efforts and thank you for this important work as well. I'd like to next welcome and introduce our committee co-chairs, Dr. Kimberly Gregory and Dr. Martha Carter, and give both of them a chance to provide some welcoming remarks. I'll first turn to Dr. Gregory to kick things off.
Good morning, everyone. It's exciting to see everyone. I look forward to a very robust discussion today. And actually, since I'm post-call, I want it to be very stimulating so that I can stay awake. It's very good to see you, and welcome.
And good morning, everybody. Martha Carter here. Like has already been said, I think we're going to have a very interesting discussion today. We've got some really interesting measures and some measures for testing. So thank you all for taking time to do this important work. I'm in a little cabin in Montana, and I hope that my internet connection holds. And if you see the ducks and the geese on the curtains in the background, you know why.
Great, thank you both. I'll turn things to Hannah Ingber now, the NQF team, to review some housekeeping reminders.
Thanks, Tammy, and good morning, everyone. I just want to review a few brief housekeeping reminders for the meeting today. As most of you know, we're using the WebEx platform to host this meeting. And although there are inherent challenges with using a virtual platform, we want to make this the best experience possible. So if you're having any technical difficulties, please let us know. Our team is ready to assist you via the chat or by emailing us directly at perinatal@qualityforum.org. In the spirit of engagement and collaboration, we encourage everyone to turn on their video if you're able to do so, and if you have the bandwidth, so we can see each other's faces and bridge some of those virtual gaps. If you're not actively speaking, we ask that you please place yourself on mute to minimize background noise and interruptions. To mute, click on the microphone at the bottom of your screen, and to unmute, you can click that microphone again. We also encourage use of the raise hand feature. That's also at the bottom of your screen next to the little smiley face. You can click that to raise your hand and then click it again to lower your hand. Shortly, our Senior Managing Director, Tricia Elliott, will conduct roll call and review disclosures of interest. It's important to note that we are a voting body and therefore need to establish a quorum to vote during our meeting today. So if you need to step away from the call at any moment, we'd like you to just please notify NQF's team using the chat so that we can maintain an awareness of attendance and quorum numbers throughout the meeting. Next slide, please. I'll pass it back to Tammy now. Thank you.
Thank you, Hannah. Now I will briefly introduce the project team supporting this perinatal and women's health project today. As I said, my name is Tammy Funk. I'm the director here. Erin Buchanan is our senior manager. Hannah Ingber is the manager. Sean Sullivan is our associate. And we're also supported by some additional staff today. Poonam Ball, our senior director. Yemi Kidan, our senior project manager. And Jesse Pines, our clinical consultant, could not make the call today, but has supported the work throughout this cycle. Next slide, please. Great, now I will briefly review today's agenda. We'll begin by taking attendance, and we'll ask committee members to state any disclosures of interest. After this, Erin will provide an overview of the evaluation and voting processes. Sean will then conduct a voting test. As usual, for voting today, we'll be using Poll Everywhere, an online platform for our live voting process. You should have received an email this morning with a Poll Everywhere link, and that link has also been added to the calendar invite. When you sign into the Poll Everywhere platform this morning, please make your username your actual name so that staff can better troubleshoot any missing votes or technical issues. If you can't find the link in either place, please send the team a chat and we'll be happy to send you another link. Please do not paste the link into the general chat at any time, as it's critical to our process that we isolate the voting to standing committee members only. After the voting test, I will briefly introduce our measures under review, and then I'll hand discussions over to our co-chairs to facilitate the consideration of each measure. The standing committee will discuss each criterion in order and then vote on each criterion. The last vote will be an overall recommendation for endorsement for the measure. Following the discussion of all measures today, we will review related and competing measures for any measures that were recommended for endorsement. We'll then host an opportunity for NQF members and the public to voice their comments, and we'll conclude with next steps and what to expect moving forward, and then we'll adjourn. I want to point out that we have planned to achieve review and voting of all 4 measures during today's meeting. However, you should still have a calendar invite and time reserved for this Friday, July 8th from 10 a.m. to 1 p.m. Eastern. If we do not complete discussion and voting of the measures under review today, we will reconvene on Friday the 8th to complete the agenda. If we do make it through the agenda today, Friday's meeting will be canceled. Next slide, please. Okay, I will hand things to Tricia Elliott to conduct roll call and disclosures of interest.
Great. Thanks so much, Tammy. And thank you everyone for your time today for this very important CDP meeting. Today we will combine introductions with disclosures of interest. You received 2 disclosure of interest forms from us. One is our annual disclosure of interest and the other is disclosures specific to the measures we are reviewing in this cycle. In those forms, we asked you a number of questions about your professional activities. Today, we'll ask you to verbally disclose any information you provided on either of these forms that you believe is relevant to this committee. We are especially interested in grants, research, or consulting related to this committee's work. Just a few reminders. You sit on this group as an individual. You do not represent the interests of your employer or anyone who may have nominated you for this committee. We are interested in your disclosures of both paid and unpaid activities that are relevant to the work in front of you. Finally, just because you disclose does not mean that you have a conflict of interest. We do verbal disclosures in the spirit of openness and transparency. We will now go around our virtual table, starting with our committee co-chairs. I will call your name. Please state your name, what organization you are with, and if you have anything to disclose. If you do not have disclosures, please just state that I have nothing to disclose to keep us moving along. If you experience trouble unmuting yourself, please raise your hand so that our staff can assist. Okay, Martha Carter.
Yes, good morning, Martha Carter. I have nothing to disclose.
Thank you. Kimberly Gregory.
Hi, good morning. I'm Kimberly Gregory. I'm Vice Chair for OBGYN and Quality Improvement at Cedars-Sinai Medical Center. And I have a PCORI grant developing a childbirth patient satisfaction survey, a NIH grant on, what they say, I had an NIH grant on measuring severe maternal morbidity on patients with accreta and placenta previa. And I've served on several committees as expert providing opinions regarding the use of the NTSV measure, for example, with Leapfrog and the U.S. News World Report, and the Joint Commission for the measure, for the SMM measure.
Thank you, Dr. Gregory. Next up, we have Jill Arnold.
Good morning, this is Jill Arnold. I'm here as a consumer advocate and I have nothing to disclose today.
Thank you, Jill. Matt Austin.
Yeah, good morning. My name is Matt Austin. I'm an associate professor at the Johns Hopkins Armstrong Institute for Patient Safety and Quality. And my only disclosure is I have a contract with the Leapfrog Group to help support their measurement activities, which includes a number of maternity care measures, none of which explicitly we'll be reviewing today.
Great. Thank you, Matt. Jennifer Baylett. Okay, we'll circle back. Amy Bell.
Hey, good morning. I'm Amy Bell. I'm the Assistant Vice President for Performance Improvement and Atrium Health in the Greater Charlotte region, and I have nothing to disclose.
Thank you. Tasha Cooper. Okay, circle back. Christina Davidson.
Hi, good morning. I'm present and I have nothing to disclose.
Thank you. Ashley Hooray. Okay, we'll circle back. Lisa Holtzclaw.
Good morning. This is Lisa Holtzclaw, ACNO. I work at Mission Hospital. I'm representing HCA Perinatal Advisory Team, and I have nothing to disclose.
Thank you. Next is Mambaramba Bath Jalil. Excuse my pronunciation.
That's fine, Mambaramba Jalil. You can call me Jalil. I'm an associate professor at the University of Texas, Southwestern Medical Center in Dallas, Texas. I'm a neonatologist by training, and I'm the medical director for the NICU at Parkland Hospital in Dallas, and also the associate chief for the division of neonatology. I have nothing to disclose.
Excellent. Thank you. Diana Joles.
Good morning, Diana Jaldas, and I have nothing to disclose.
Thank you. Elizabeth Jones. Okay, circle back. Sue Kendig.
Hi, I'm Sue Kendig. I am a women's health integration specialist with SSM Health in St. Louis and a director of policy for the National Association of Nurse Practitioners in Women's Health, and I have nothing to disclose.
Thank you. Deborah Kilday.
Good morning, everyone. Deb Kilday. I serve as the principal for Premier's Women and Infant Services and support the HHS Office on Women's Health Maternal Infant Data Analysis Initiative, and have served as an advisor and technical panel expert for the EPCO7 Severe Complications Advisory panel. I have nothing else to disclose.
Thank you. Sarah McNeil? Jennifer Moore? Sarah Nathan? Sheila Owens Collins?
Hi, I'm here. I am President and CEO of Neonatal Perinatal Medicine and Health, and I have no disclosures.
Thank you. Diana Ramos? I will circle back. Sindhu Surinbias, sorry.
No problem. Good morning. Sindhu Srinivas from the University of Pennsylvania. My only disclosures are I'm a practicing obstetrician, maternal fetal medicine specialist who does inpatient labor and delivery care. I'm the vice chair for quality and safety at Penn in the Department of OBGYN and physician lead for the Women's Health Service Line at Penn Medicine. And I have a few research projects and grants looking at different care delivery models and their impact on severe maternal morbidity.
Thanks so much. Nan Strauss? Angeline T? Rajan Hawan?
Hey, good morning. This is Raj Wadhavan. I'm a neonatologist by clinical training, and I serve as the Senior Executive Officer for Advent Health for Children and Advent Health for Women in Orlando. No disclosures.
Okay, thank you very much. I am going to circle back and call some names one more time just to make sure we didn't miss anybody or if someone joined a little bit late. Jennifer Baylett? Tasha Cooper? Ashley Hooray? Elizabeth Jones? Sarah McNeil? Jennifer Moore? Sarah Nathan? Diana Ramos? Ann Strauss? Angeline T. Okay. Thank you, everyone, for participating in that. I'd like to let you know that if you believe that you have a conflict of interest at any time during a meeting as topics are discussed, please speak up. You may do so in real time during this meeting, or you can send a message via chat to your co-chairs or to anyone on the NQF staff. If you believe that a fellow committee member may have a conflict of interest or is behaving in a biased manner, you may point this out during the meeting and send a message to your chairs or to the NQF staff. Does anyone have any questions or anything you'd like to discuss based upon the disclosures made today? Okay, hearing none. As a reminder, NQF is a nonpartisan organization. Out of mutual respect for each other, we kindly encourage that we make an effort to refrain from making comments, innuendos, or humor relating to, for example, race, gender, politics, or topics that otherwise may be considered inappropriate during the meeting. While we encourage discussions that are open, constructive, and collaborative, let's all be mindful of how our language and opinions may be perceived by others. With that, I will turn things back to the team. Thank you.
I think Erin Buchanan will now review our evaluation and voting processes.
Good morning, everyone. Thank you for joining. So as a reminder, as a standing committee member, your role is to act as a proxy for the NQF multi-stakeholder membership. You'll evaluate each measure against each criterion, indicating the extent to which each criterion is met and rationale for the rating. You respond to comments submitted during the public commenting period, as well as make recommendations regarding endorsement to the NQF membership and oversee the portfolio of perinatal measures. Next slide, please. So just to lay the founding of today's meeting, here are some ground rules. Please be prepared, having reviewed the measures beforehand. Please respect all voices, as we mentioned before. Please remain engaged and actively participate. Please base your evaluation and recommendations on the measure evaluation criteria and guidance. And we also ask that you keep discussions of criteria in their own conversation. Keep your comments concise and focused. Be respectful and allow others to contribute. Share your experiences and learn from others. Slide, please. So here's a reminder about our process for measure discussion and voting. We'll kick things off with a brief introduction by the measure developer. Then the lead discussant will begin the committee discussion for each criterion by briefly explaining information on the criterion provided by the developer, a summary of any pre-meeting evaluation comments, emphasize areas of concern or differences of opinion, and also note the NQF preliminary rating. And just as a reminder, that rating is intended to be used as a guide to facilitate the committee's discussion and evaluation, and the committee can always choose a different rating. Developers will be available to respond to questions at the discretion of the committee, and the full committee will discuss, then vote on the criterion if needed before moving on to the next criterion. So discussions for a given criteria are within that area of discussion, and then if topics come up related to other criterion, we'll hold those topics until we get to that criterion. Next slide, please. So here is an overview of our endorsement criteria, which you all saw in the PA. So the first criteria is importance to measure and report, which contains evidence and performance gap. That is the extent to which the measure focus is evidence-based and important to making significant gains in healthcare quality, whether there is variation in or overall less than optimal performance, and that is a must-pass criterion. Following that, we'll discuss scientific acceptability, which contains reliability and validity. That is the extent to which the measure produces consistent or reliable and credible, valid results about the quality of care when implemented. Those are also must-pass. We'll discuss this later, but there are two measures today which we won't discuss all of reliability, just specifications, and we won't discuss the validity, but we'll get into that a little bit later. Following that is feasibility, the extent to which the specifications require data that are readily available or can be captured and implemented without undue burden. Following that is usability and use, the extent to which the measure is being used for both accountability and performance improvement to achieve the goal of high quality, efficient healthcare. This is must pass for maintenance measures. And then finally, there is the comparison to related or competing measures. And that conversation will actually happen after all of the voting has taken place, once we know whether or not measures are recommended for endorsement. Next slide, please. So here is a high-level overview of what I just described, detailing what criteria are pass and must pass, or are not must pass or can be moved on. Something I'll note is there's also a vote for overall suitability for endorsement. Next slide, please. So in terms of procedural notes, if a measure fails on one of the must-pass criterion, there's no further discussion or voting on the subsequent criteria for that measure. The committee discussion moves to the next measure. If consensus is not reached, the discussion continues with the next measure criterion, but a vote on overall suitability will not be taken. Next slide. So here are our numbers for today. I think we have 23 active standing committee members. So 66% of that is 15 people. So as a reminder, votes of yes comprise of high and moderate votes. On that number of active voting eligible standing committee members who participate in the voting activity. CNR measures move on to public comment, and the committee will revote during public comment or after public comment during the post-comment web meeting. Measures which are not recommended will move on to public comment, but the committee will not revote on the measures during the meeting unless the committee decides to reconsider them or a reconsideration request is requested by the developer. Just as a note here, the quorum denominator will change if any standing committee members are recused from discussion for a measure. Next slide, please. So please let us know if you need to leave at any point during the meeting. We must have quorum to vote, and discussion may occur without quorum, but only if we have 50% of attendance. If we don't have quorum at any point during the meeting, live voting will stop and staff will send a survey link as well as the recording of the meeting within 48 hours. And there will be 48 hours to complete that survey. If a committee member leaves during the meeting and quorum is still present, the committee will continue to vote on the measures. The committee member who left the meeting will not have the opportunity to vote on measures that were evaluated by the committee during their absence. Next slide, please. All right, do we have any questions about the evaluation process? All right, hearing none, I will pass it back to Tammy.
Thank you, Erin. I'll actually lead us in the voting test now. So as Tammy mentioned before, everyone should have received a Poll Everywhere voting link in your email this morning between 5:15 and 8:15 a.m., depending on your time zone. If anyone is not able to access the voting link, please do let us know and staff will assist. So for our test question for today, do you prefer the Beatles or the Rolling Stones? And our options are A for the Beatles and B for the Rolling Stones. And I believe we are looking for a total of 14 votes for our test question today. So again, if anyone has trouble accessing the voting link in your email or on the calendar invite for the standing committee, please do let us know and we will assist you with that. Just a couple more votes shy here. We are at 12 votes. If anyone has any trouble accessing the Poll Everywhere voting link, please let NQF staff know and we will assist.
I'll chime in with a reminder that the link was sent to the email for everyone on the standing committee this morning, and we also added it to the standing committee invitation, calendar invitation. So please let us know if you can't access it. If you think you are voting right now, please double check that your vote is submitted because we are expecting a few more.
We are just 2 votes shy, so.
This is Kim. Can I confirm if it turned blue that it was submitted, right?
Yes.
Okay.
Thank you, Kim.
Could you please forward that link again? Copy and paste is not working and I cannot find that email in my email. This is
Sure.
rajan.woodhaven.md@adventhealth.
Of course. Thank you, Rajwan. Just wait 1 more minute here.
Sean, this is Martha. While we're waiting, can you remind me when we, well, we may not have enough to vote on the measures, but if we do we need to close out that link with each vote, or can we just refresh it?
So it will be the same link, and each question for voting will be activated for when the voting time occurs. So you don't have to refresh the link each time. The questions will just appear when we activate.
Can I ask another note of clarification? Because I heard you say that there were 14 votes you're expecting, but we need 15, right?
Yes, I know we're
Take that one, Sean.
Sure, Tammy, go ahead.
Yep, we're at the moment we're counting 1 short of quorum for our voting. So the team has emailed all of those who aren't currently on the call to remind them if they're planning to join to please do so ASAP so that we can begin live voting. We did receive enough disclosure forms and RSVPs to believe that we will have quorum on the call. So we're hoping the rest of your colleagues will join shortly. We'll proceed up until the first vote with the expectation that we'll be live voting, but before we get to that evidence vote, we'll double check our numbers.
Hi, this is Sheila Owens Collins. So can I confirm that you received my vote?
Yes.
Okay, thank you. Because there's no submit and you don't know. Okay, thank you.
Mm-hmm. Just confirming your vote, Sheila. Thank you.
Oh,
yes,
sorry.
everyone. Thank you for your
Sean.
vote so
Yeah,
much.
you're
So
good.
just to confirm the test question, do you prefer the Beatles or the Rolling Stones? 62% for the Beatles, 38% for the Rolling Stones. And I will turn things back over to Tammy to introduce the measures under discussion today. Thank you all so much.
Great. Thanks, Sean, and thanks, everyone. Again, we will check our numbers before we get to our first vote of the day. And at that point in time, if we do believe we have quorum, we will definitely be collecting all votes. So if you're having any trouble at that point, the team will be helping to troubleshoot via direct chat or email, whatever you need to make sure we get those votes collected. Okay, next slide, please. So we have 4 new measures under consideration today, 2 of which are being reviewed for trial use. The first measure discussed today will be 3687E, EPCO7, Severe Obstetric Complications. The developer is the Joint Commission. The next measure under review is 0471E, EPCO2 cesarean birth. The developer is again the Joint Commission. The last two measures under review today are not seeking full endorsement, but rather approval for trial use. We'll share more information about the status before the committee begins its discussion and voting on these measures, so that it's fresh in your mind before we move in. The first of these measures is 3682E, Think-Based Contraceptive Care Postpartum, and the developer is the University of California, San Francisco. And the second of these two measures, and the last measure under review today, is 3699E, Think-Based Contraceptive Care Non-Postpartum. The developer is again the University of California at San Francisco. Next slide, please. Now, a quick review of the scientific methods panel. This is a group of researchers, experts, and methodologists in healthcare quality and quality measurement. The SMP reviews complex measures, and the panel's comments and concerns are provided to the developer so that they can provide further clarification and update their submission to strengthen measures that are to be evaluated by the standing committees. Next slide, please. 3 perinatal and women's health measures were reviewed by the SMP this cycle: 0471E and 3687E, which I listed in my introduction, and 0716E, unexpected newborn complications in term newborns. Measure 0716E did not pass the SMP evaluation of reliability and validity. For measure, so this measure was eligible to be pulled for discussion by the standing committee, but the standing committee did not elect to do so. So this measure is not under review today. For measure 3687E, the SMP passed the measure on both reliability and validity. For measure 0471E, the SMP did not reach consensus on either reliability or validity. 3687E and 0471E will be discussed and voted on by this committee today. Next slide, please. Okay, and with that, we will now begin the review of our spring 2022 measures. To remind you of the flow, our co-chairs will start us off by introducing the measure. They will then turn to the developer, who will have 3 to 5 minutes to provide a brief overview of their measure. The co-chairs will hand things to the lead discussants, who will summarize the measure and review committee and public comments. During the discussion, any questions from the standing committee for the developers will be noted by the NQF team and your co-chairs. After sufficient discussion, the co-chairs will pause and pose each question to the developer for a response. Discussion will then turn back to the standing committee. If at any time during the discussion, the developer team would like to address an inconsistency they hear or clear up some confusion, we ask you to please use the raise hand feature or put your request in the chat. That way the co-chairs can call on our developers to speak at the right time. The full committee will be discussing and voting on each of the measure criteria. I'll check first if the first developer is on the line. Is someone from the Joint Commission on the call today?
Hello, yes, this is Chris Wallace. Joint Commission is on the call. Thank you.
Great, excellent. And with that, Kim, I think I'll hand the first measure over to you.
Great, thank you very much. We'll be listening and reviewing to measure 3687E, which they're calling EPC 07, severe obstetric complications. It's a new measure. It's described as a hospital level measure that scores are calculated as a risk-adjusted proportion of the number of delivery hospitalizations for women who experience a severe obstetric complication. In the numerator, divided by the total number of delivery hospitalizations in the denominator during the measurement period, and it will be reported as a rate per 10,000 delivery hospitalizations. It is an outcome measure. The level of analysis is at the facility, and the setting of care is the inpatient hospital, and the information will be coming from the electronic health record. I will now turn it over to Chris to discuss.
Hello, thank you. Thank you for allowing us the opportunity to speak to you about severe obstetric complications measure. Maternal morbidity and mortality pose serious health threats to pregnant women in the United States, where rates have been on the rise in comparison to other developed countries. Consequences of maternal morbidity are well documented. Not only are these conditions leading causes of pregnancy-related death, but often lead to further pregnancy complications and other SMM conditions. Costs are incurred due to the treatment required by obstetric complications and the impact on hospital lengths of stay. Premier's Bundle of Joy report 2019 found that women with SMM delivering vaginally have hospital stays that are up to 70% longer than women with vaginal deliveries experiencing no SMM. There are also considerable racial and ethnic disparities in maternal outcomes. Historically, marginalized women of color are at a significantly higher risk for developing severe maternal complications compared to non-Hispanic white women. Non-Hispanic Black women are 3 to 4 times more likely to die from pregnancy-related causes than non-Hispanic white women. The high maternal mortality and morbidity rates in the United States present a unique opportunity for large-scale quality improvement activities and measurement. Statistics on preventability vary, but suggest that a considerable portion of maternal mortality and morbidity events could be prevented. A 2019 report from 14 maternal mortality review committees conducting a thorough review of pregnancy-related deaths determined that 65.8% of them were preventable. Using the CDC definition of SMM, the U.S. median rate was 1.4% and the highest hospital rate was 12.2%. National attention has been brought to maternal morbidity and mortality events. There are numerous state agencies, private and/or nonprofit organizations, and collaboratives that have spearheaded maternal health and quality improvement initiatives. However, national evaluation of hospitals' performance on maternal morbidity and mortality is limited because there are currently no maternal morbidity or obstetric complication outcome measures in national reporting programs. Therefore, the development of an obstetric complications outcome measure addresses a national measurement gap that can build on learnings from existing maternal health initiatives and measures. In collaboration with Yale New Haven Services Corporation Center for Outcomes Research and Evaluation, CORE, and with the guidance from our expert advisor, Dr. Elliot Main, CMQCC Medical Director and Executive Committee Chair, we have developed an electronic clinical quality measure for severe obstetric complications. This measure is expected to inform hospital efforts to improve maternal health outcomes and thus reduce the costs associated with adverse health outcomes. We sought to keep the measure specifications harmonized with other perinatal measures for cohort alignment and with the Center for Disease Control's 21 indicators of SMM for harmonization of the measure outcome for broad applicability across hospitals. The measure was developed in consultation with 23 clinicians, patient, and other stakeholders across 6 meetings. This measure also aligns with Healthy People 2030. Given the limited nature of ECQM test data, we have data from 25 sites and now results from an additional 5 sites. Even with that limited data, you can see there is variation in risk standard scores. Now 166 to 374 per 10,000 for the overall SOC and 50 to 67 per 10,000 for SOC excluding the blood transfusion only. The current proposed measure has emphasized screening for pre-existing conditions, adds additional information from the EHR, vital signs, and lab values, and uses a case mix-based risk adjustment for comorbidities. The nearly identical measure without lab and vital signs has been straightforward to operationalize, complete with case mix adjustment over the last 3 years in over 300 hospitals and nearly 550,000 annual births in the state of California, Washington, and Oregon, CMQCC Maternal Data Center. After several months of case reviews, hospitals quickly learned to rein in exuberant and other coding practices, and CMQCC has gotten positive feedback as to how the measure has helped guide maternal QI and particularly been useful for examining racial and ethnic disparities. There has not been any evidence of harm, real or otherwise, in its use to guide hospitals now in over 1.5 million cases. We will continue to monitor the severe obstetric complications ECQM during routine maintenance to ensure the measure properly informs hospital efforts to improve SMM. Thank you.
Okay, I'm going to now ask for the first discussant to share their comments. I think
Good morning,
that's
everybody. Yeah, that's me. Thanks, Kim. Hi, everybody. Sindhu Srinivas again. I'm happy to be a discussant for this new measure. I think the developers the developer that just presented did a great job of kind of laying out the background of why a measure like this is important. So our first sort of criteria of importance to measure and report, which is a must-pass criteria. You just heard about the sort of, we know that there's significant variation and high rates of severe maternal morbidity and mortality. There's multiple scientific articles and reviews of maternal mortality review committee work across the country that demonstrate the need for consistent evaluation of severe maternal morbidity, or in this case, this measure, which is a new measure for acute care hospital. It's the level of analysis is at the facility level, as we heard, and it is an outcome metric that in the logic model that the developer presented in our pre-evaluation demonstrates the concept that this outcome is directly related to processes that can be intervened upon once reviewed to try to implement new processes. So it's a metric that's meant to be kind of used in parallel with process and quality improvement implementation to then thereby reduce the outcome. In terms of there's a few kind of things to mention that were brought up in the comments from the committee and from comment. In terms of and I guess I'm going to throw some of these out there, but I know we may have to come to them in sort of different parts, but I'm going to sort of summarize some of the overarching sort of concerns. And one is sort of the question of whether there should be a limit in the number of births, in whether that's in the number of 200 births in terms of the reliability of the metric was sort of mentioned. It's not clear exactly what happens when a hospital receives transfers, both from birth centers or from births at home or from other facilities, in terms of how those patients will be treated and attributed, and from the facility perspective. There was concerns raised about I think the risk adjustment modeling for this metric attempts to try to get at some of the pre-existing conditions that might be present and contributing to this outcome. But there are things brought up around social determinants of health, and the ability of coding to accurately detect those things was brought up. And then the concern about, as we just heard, significant racial and ethnic disparities in this outcome and variation, but we don't want to risk adjust for that, but want to have the metric that is stratified and reported by race. And that sounds like it's still under development and not ready sort of for use in that way quite yet. And that was a concern that was raised as well. I don't know if I think Sue Kendig is the other discussant, and whether she has anything else she would like to add.
Sue?
Yeah, hi. Thank you. Was trying to get off mute. No, I think that you summed it up pretty clearly. Again, underscoring the concern about continuing to work on the ability to stratify the results for further information. And while the measure looks at issues that can be subject to intervention by the clinician, the limited information around social determinants in this was a concern. So thank you.
Okay, I believe, Matt, I know that you're on the SMP Standing Committee, but did not participate in the vote for this measure. Is there anything that you'd like to add or share with the committee?
Not at this time. Yeah, thank you. I didn't review the measures. I wouldn't be able to really offer anything. So thank you.
I think the couple of other things that I'll add to what I've in summarizing some of the unintended consequences of this measure that were raised by comment as well. Some brought up that while it is trying to align and create a measure that is easily reportable and comparable across hospitals, that it doesn't capture all morbidity necessarily, and there's a concern that it might miss this current metric and its current definition of those 21 conditions might miss some morbidity, that it might sort of lead to a focus on improved coding rather than improved care, since it's coding based, and that might lead to a shift in hospital resources that will focus on sort of the coding and review and completion rather than the actual care processes that understanding this metric and then following up on might impact.
I'm sorry to interrupt. This is Poonam from NQF. I think we're straying a little far from evidence that is unintended consequences fall under usability. So we'll definitely get to that. And then also
Sure.
we'll just remind the committee that risk adjustment or stratification is under validity. So that also discussion would fall under there. I just want to make sure that we're focusing on the evidence right now, and then we'll definitely get to all those topics. Thank you.
Great. Thanks for refocusing us, because I think when we talk about the measure, it's hard to kind of keep in that one lane. But I think from the perspective of the evidence and importance to measure and report, I think there's clear evidence that a metric around severe obstetric complications, and there's clear variation and a need for this type of metric, that there's enough evidence that supports that premise.
Okay, I'm opening it up to the committee. Any other comments or questions that we might want to share with the developer before moving to the criterion? Okay, Christina.
Hi, can you hear me?
You could be a little louder.
Any better?
No? Okay, we can hear you.
Okay. I'm also maternal fetal medicine. Use this measure quite a bit at my hospitals. We, over the last few years, have been even reviewing these cases in our quality and safety committees. And I think overall, in general, it's probably the best measure out there to try and look at something like this. However, we have recognized that a lot of these conditions capture things that may not necessarily be amenable to like a quality and safety implementation process. And so, for example, amniotic fluid embolism. We know that that's a very rare and life-threatening event that's not predictable or preventable. And so some of the conditions, even though there may not be a lot at any given hospital, could potentially weigh towards, there's a high morbidity, but there's really nothing you can do about it. And I think, with hemorrhage, we know that blood transfusion drives the SMM rate nationally. However, there's also concern that it would lead to, and this may be straying into another part of the discussion, but there's concern that it would lead to people withholding transfusion to try and lower their rate. And so, we wouldn't want something like that to happen. And then the present on admission, I think, is another. I work at 2 hospitals that are level 4 maternal hospitals, get a lot of transfers. And so, the hospitals that take care of the highest acuity are also potentially going to have higher numbers of this. And, if there's an accounting for present on admission, that may be helpful. But, some of these things are really more impacted before they get to the hospital. And so would a hospital get dinged for something that, they didn't necessarily have the ability to help with before the patient presented? And then hysterectomy is one that I've struggled with a lot, because we consider ourselves a placenta accreta spectrum referral hospital. And so I think the hysterectomy one should also be, if the patient is a planned hysterectomy for placenta accreta, which is confirmed on pathology, should that be considered the same way of a patient who, you just couldn't get her hemorrhage, her uterine atony under control, and ultimately had to do a hysterectomy, or there was delayed treatment of that. So I think some of the individual measures, when we implemented the OB hemorrhage bundle, it really helped to look at the transfusion. But as we're going through hypertension, the main ones from hypertension, like pulmonary edema and acute renal failure, oftentimes that's how you get the diagnosis of preeclampsia with severe features. It's not necessarily the result of mismanagement, so to speak. And so again, it's almost like what came first, the chicken or the egg? Did you get pulmonary edema and acute renal failure, presented, got diagnosed with preeclampsia with severe features, and then got delivered? Or did you get diagnosed with preeclampsia with severe features off of your hypertension, and then we didn't manage you appropriately and put you into pulmonary edema or acute renal failure? So I think when you break down each individual measure and you're really reviewing those cases, some of them are hard to say that as a composite measure, this is how we should be measuring hospitals. I hope you could hear all of that.
Yes, it was very clear. You got louder as you got more excited. So we heard you quite well. Thank you very much.
Can I ask a question, actually? So, Christine, I agree with a lot of the things that you said. So in this first vote around kind of the importance to measure and report, or that aspect, is that where we're talking about, like, you're bringing up ways to refine the measure potentially? And so I guess I'm sort of, just to be clear on, is that what are we suggesting, sort of refining aspects now, or are we first sort of voting on the fact that this should be measured in some way?
If that was a question for NQF, the answer is you're voting on the measure as it's before you. So you are welcome to make suggestions for a future review for the developer to take into account, and those get captured in our technical report. But you're considering the measure as submitted today.
Okay, are there any other committee questions or comments before I refer back to? I see that Dr. Mean wants to address, but I want to make sure we get all of the committee responses. Okay, Elliot?
Thank you, Kim. I think one of the struggles we have is we're following NQF directives to really focus on outcome measures. Is the challenge of any measure that looks at mortality and or morbidity. There is no outcome measure that will entirely focus on preventable activities. All outcome measures will have elements of cases that are not preventable, that have all the issues that were just mentioned. So I would look at this measure as one that does a fair job of collecting areas that are preventable, but it will clearly pick up a number that are not preventable, which is the case for any outcome measure. Secondly, I think that the way to address that is through case mix adjustment, so that women who have hypertension, chronic hypertension, or even accretas are adjusted for in the outcome measure, which is more than what will happen with the pure CDC measure. So with present on admission adjustments and case mix adjustments for underlying comorbidities is really, I think, the state of the art for dealing with outcome measures. Thank you.
Any other comments for the committee?
Can I make one other comment? I think that I do agree that this, while it has some limitations, as were just mentioned, it is a measure that is needed, and a standardized measure is needed around this type of metric, given the state of maternal morbidity and mortality in the United States. I think that I guess my question is sort of whether the metric is ready for sort of, or what I'm throwing out to the committee is whether the metric is ready as is prior with the current present on admission exclusions and risk adjustment, which I think is a pretty extensive risk adjustment, which I thought was well done in terms of the extensiveness of that. but without the race-based stratification piece fully figured out. And a potential, and this is a comment maybe for the technical report, that we're, in addition to actually reporting this measure by hospital, actually having hospitals maybe even, and this is more work, but if we're really trying to get at reduction of morbidity, actually getting at the ones that were potentially preventable and what sort of process mapping, what process improvement implementation actually maps to preventing that outcome the next time, so that it's clear that this is meant to improve processes that are eventually meant to improve outcomes. So Christina, your example of the amniotic fluid embolism, yeah, that might not be preventable, but was there good response? Was the checklist implemented? What, the outcome might not have differed, but the way to potentially, resolve or improve that outcome is to have implemented processes that were used, and were those processes in place? And if not, is that the next step? And it would be nice to see sort of a combination sort of reporting for hospitals that really tries to foster quality and process improvement to get at outcome improvement.
Yes, Chris.
Thank you. I just wanted to clarify that we are doing race stratification. Is that something you would like to go into more detail about now, or is that something later that we can comment on that?
I'm going to ask NQF if it was proposed that that's part of the plan, but it wasn't submitted as part of the measure. So are we voting as though it's going to be part of the measure, in which case we would like to hear about it, or we're only voting on what we have evidence for?
We're only voting on what was currently submitted as the measure in front of you for review. And just a reminder, this first vote in the importance to measure report will be just on evidence. The next discussion and vote will be on a performance gap. I just want to keep this first discussion to evidence. I guess the question that I would have, and then I saw you, Christina, raise your hand again, is the model itself. How does the average hospital do all that modeling?
I would like to call on Valerie from CORE, please, or Katie, to respond to that.
Hi, Kim. Before we jump into this, this is Poonam. We are veering really into reliability, which is specifications, and into validity. We really want to focus on, is the evidence that's provided showing that this is a measure that should exist and is needed in health, in the current healthcare system. Well, I agree all of these are really important discussions. I want to make sure that we're talking about them in the appropriate section. So diving into the specifications would be reliability, and then diving into the model that they've created to adjust for these issues would be validity.
Thank you for being a great taskmaster. And I think if there are no other comments from the committee, I believe we have quorum, and we can address the first item so we can get to some of the other stuff.
We do, and I'll jump in and ask, I think Jennifer Baylett has joined us. If you could introduce yourself, your name, organization, and state if you have anything to disclose.
Hi, good morning. My name is Jennifer Baylett. I'm a maternal fetal medicine doctor here in Cleveland, Ohio. I'm the Chief Medical Officer for Inpatient Services here at Metro Health Medical Center. My research is focused on measuring and improving quality of care, particularly maternal care in the labor and delivery setting, although some in the outpatient setting. I've also, in previous lives, been the PI for the MFMU for our center. I've been on NQF, I think, for several years. I was trying to remember exactly when I started, but it's been a bunch of time now. Thank you.
Great, thank you so much. And yes, we do believe that we're at quorum, so we can proceed with live voting. So Kim, were you turning it over to us for the evidence vote?
Yes,
okay.
Please.
I'll hand it to Sean.
Thank you, Tammy, so much. So voting is now open for measure 3687 1A, importance to measure and report evidence. Your options are pass and no pass. And just as a reminder, we are looking for a total of 14 votes for this measure, 3687E, due to Deb Kilday being recused. So we're looking for a total of 14 votes for this measure. And again, if anyone has trouble accessing the Poll Everywhere link via the email or standing committee calendar invite, please do let NQF staff know. We will assist you. Looks like we are waiting on a couple more votes. Yes, Jennifer, I saw your chat. So we sent the Poll Everywhere voting link via email this morning around 8:15 on the Eastern side, and it is also copied to the standing committee calendar invite for this meeting today as well. Just 2 more votes here.
I think Kim asked this before, but if it's blue, the vote went through. Correct.
Correct, yes.
And just a reminder, we do need every vote to achieve quorum. So we're taking a peek on the back end to see if we can figure out whose vote isn't being captured, and we'll try to direct message you if we see an issue.
I'm trying, yeah, this is Sheila Collins. I've lost the link, and so I'm finding it again, but I'm getting ready to vote.
Thank you, Sheila.
The downside of not being in person.
Still waiting on 2 more votes.
Just send me the link again, please.
Of course, Sheila. Thank you. And looks like we have, well, we are at 14 votes, so I will go ahead and lock the poll. We will do a quick calculation on our end. For measure 3687E, importance to measure and report 1A evidence, we have 14 votes for pass and 0 votes for no pass. Therefore, the measure passes on evidence. And I will turn it back over to Kim to lead the discussion on performance gap.
Okay, can I have my talk about the performance gap for this measure? Srinivas?
Yes, sure. So I think we started to creep into this discussion a little bit. One gap is that the measure before us, we know that there's significant racial and ethnic disparities in this in severe obstetric complication. While I think Chris was going to say, it sounds like that's under development, and the measure before us to vote on is not, that evidence for that was not provided. So currently the measure is not being reported by race and ethnicity stratification. The other thing that I wasn't completely clear on, or that I guess was around some of the risk adjustment. There was risk adjustment that was pre-existing or present on admission conditions. And then there were some vital sign aspects that it sounds like when they were removed, it performed just as well. And then there was some social determinants of health metrics around, or criteria around like housing stability. And I wasn't clear on whether that was in the final risk adjustment or not, and concerns around kind of ascertainment of those pieces. Those are, I think, two of the main gaps. The racial stratification, race and ethnic stratification being the main one, or one main one.
Hi, this is Poonen from NQF. Sorry for jumping in again. I know this is always a little confusing with performance gap. So for here, we're just trying to see if there's a gap, and based on disparities or in general is a gap, and then we'll focus on how they adjusted for those disparities and what those concerns were in validity.
Okay, well, I think that makes this piece of the roadmap clear. Not biasing anyone with my opinion about the presence of a gap. Are there any committee questions for the developers about that question in particular? Do we think that there's a gap? And hearing none, I think we can vote on that. And then regroup. So I'm going to call for a vote on whether or not there is a gap demonstrated in this measure or this outcome.
Christina commented in the chat that there's a gap based on the fact that it's not stratified by race and ethnicity.
Okay.
Oh,
And
is this
that's
a yes, no gap, yes gap, no gap question?
Performance gap is a high, moderate, low, insufficient vote.
Martha?
So just to be clear, we're looking at the performance gap without any stratification, but still questioning whether there's a sufficient gap in performance among hospitals that tested this measure to go forward with the measure. Is that correct?
Yes. Okay. So do we think that there is a performance gap as demonstrated by the evidence that you reviewed to go forward with this measure, rating it in the high, medium, low, or indeterminate? Hearing no further discussion, let's go to vote.
Great. Thank you, Kim. So on measure 3687E, voting is now open on importance to measure and report 1B performance gap. And again, we are looking for a total of 14 votes due to Deb Kilday's recusal on this measure. The voting link was sent via email and on the standing committee calendar invite this morning. Please let NQF staff know if you have trouble finding the link, and we will assist you.
Oh, this is so annoying.
We're looking for 3 more votes. Okay, we are at 14 votes, so I will go ahead and lock the poll. So for measure 3687E on importance to measure and report performance gap, we have 9 votes for high, 4 votes for moderate, 1 vote for low, and 0 votes for insufficient. Therefore, the measure passes on performance gap. And I will turn it back over to Kim to introduce the scientific acceptability discussion on reliability.
Okay, great. So we're now going to talk about reliability, and then there'll be a separate vote on validity. So Sindhu, can you get us started, please?
Sorry. So reliability, as people remember, I feel like I know we were crossing kind of into these different lanes a little on the early side, but just to remind everybody, demonstrates if the measure data elements are repeatable, producing the same results a high proportion of the time when assessed in the same populations in the same time period. And so there was reliability testing done for this measure and conducted at the entity level. The metric developer submitted the multiple sort of individual hospitals and then hospital systems with multiple hospitals in the data that they reviewed to provide this reliability testing. So they did it from 8 pilot sites that represented 25 individual hospitals who had at least 25 deliveries a year over the calendar year 2020. And then they also calculated it for hospitals with at least 200 deliveries per year, which was 23 of the 25 hospitals. And the reliability was very good at a 0.991 level for any severe obstetric complications. And then similar, because there's been some back and forth a little bit with the measure as kind of all encompassing versus the measure of severe obstetric complications excluding blood transfusion only cases, meaning when cases are excluded where blood transfusion is the only outcome that gets the patient to have the metric present. And so they found, again, a median reliability score of 0.959 for any severe obstetric complication outcome, and then a little bit lower. So when they did it for the hospitals that had at least 25 delivery encounters, the reliability score was 0.959 for the overall measure and then 0.684 for the measure when blood transfusion only cases were excluded. And they found that the reliability was higher when they included only hospitals that had at least 200 delivery encounters for the year, which I sort of mentioned in the beginning, and in terms of some of the limits of the measure. So the 2 hospitals in there that had fewer than 200 deliveries significantly lowered the reliability when you excluded blood transfusion only cases. So again, I think the summary of reliability is that overall the reliability seems fairly high, although there's some variation and the results seem to change when blood transfusion only cases are excluded.
So do we know if the intent is to routinely exclude blood transfusions or that it's going to be an A and a B measure?
This is Chris, and it is always going to be stratified and presented as the overall rate, and then the rate with the blood transfusion only cases removed. I would like to call on my colleagues from CORE who can discuss the reliability with the blood transfusion only cases removed to help clarify that data. Valerie or Katie, did you want to speak to the blood transfusion only results?
Hi, this is Valerie Danilak from Yale. The reliability is a little bit lower for the measure with the SOC, with the blood transfusions removed. We believe that as more hospitals are added, the reliability will continue to improve. But there are smaller numbers for the outcome that has the severe sort of complications excluding blood transfusion.
Matt, did you want to raise your question?
Yeah, thanks so much, Kim. I guess I was just trying to interpret the different scenarios of different volume thresholds. It looks like the measure was calculated using a threshold of 25, and then I just lost the table. It looks like it jumps up to 200. So I was just trying to understand, and obviously the reliability improves with the higher threshold. So I guess I'm just trying to understand if the developers are recommending a certain sort of threshold of volume of deliveries needed to calculate this measure, or if that's being sort of left open-ended.
CMS will be deciding on the threshold for implementation purposes.
Okay, so for purposes of our evaluation, we should sort of consider all scenarios as being possible.
Hi, Lindsay. This is Dr. Collins. I just want to do a real quick test before you send it out. So I'm waiting to hear.
Dr. Collins, can you mute yourself, please?
Oh, sorry.
That's okay. Christina?
I may now be confusing whether this would have been a gap or reliability, but one of the other things I'm wondering about is standardization of the definitions of some of these conditions. And again, speaking a lot from personal experience, if a hospital changes what they call acute renal failure, for example, there's kind of an internal medicine definition of it, and then there's a Society for Maternal Fetal Medicine definition for it. And so I think it's like a matter of how what the hospital says is acute renal failure, and then that's how it gets picked up in coding. And that may vary from hospital to hospital, and one hospital may decide, no, that's not how we want to call it. Or we've even had conditions, it's like a double-edged sword where you're trying to capture all of the conditions you're treating from like a reimbursement standpoint, but then that may almost make it look like you have more morbidity from a hospital who may not be as good at documenting and coding. So again, I'm just wondering from a reliability standpoint, is there any plan to kind of go with a set list of definitions for some of these conditions?
Do the developers want to respond?
So this is Chris. I would like to call on Dr. Main, who has had the, has stated that the doctors currently using a very similar measure have adapted to the coding. Dr. Main, do you have any consideration for this?
This is always an issue whenever you're dealing with diagnoses, because people coding and even case reviews is dependent on what's written in the chart by the providers at the time. So we do anticipate, and we have done a lot of coding education in the 3 states that this has been tested in, without the vital signs and laboratory values that the Joint Commission has added. But there will be continuing education on this that I think will improve coding and will improve the value of this measure as we go forward. But any outcome measure is prone to those sorts of issues, and it needs to have ongoing surveillance and education as part of it. So yeah, renal failure in some places is you had oliguria for 2 hours, which isn't really the renal failure that's being discussed, as opposed to having a significant bump in your creatinine.
I guess this would be a good time to readdress the POA question and the modeling question. There's significant variability on how POA gets documented or how coders interpret POA conditions, as we've learned with the term newborn measure. And then how is the average hospital going to do the modeling?
Go ahead, Dr. Main.
Just because I'm still unmuted here. POA is something that tertiary hospitals are very familiar with and have been calling for and use extensively because they get cases referred to them that have a lot of conditions present on admission. So I'm not so worried about tertiary hospitals and their ability to code POA. Smaller hospitals with less experience, I think will have a learning curve, but they have less cases that are going to be POA attributed. In the modeling, I don't think is going to happen at the hospital level. Let me turn it back to the Joint Commission to answer that, but I think that happens centrally.
Yes, that is correct. The risk adjustment will happen centrally with the submitted data. The POA during testing, we found it to be very reliable. It is being coded. So it was actually a great way to identify cases that were present on admission. Valerie, did you have anything to add about the risk adjustment?
Sure, and just also for the POA to note that POA is used both for the outcome, so to ensure that the outcome occurs after admission, but it's also used for the risk factors to ensure that the risk factors were present before admission. So it's used in both ways. And yes, the modeling does not occur at the hospital level. The modeling will take into account risk factors across all data submitted in order to develop the risk model for all the hospitals that submit data in a given performance period. So an individual hospital does not have to do any type of modeling on their own.
So we'll probably get to this with usability, but is this a sample or everyone would be turning in all their deliveries to some central site?
It's not a sample. The hospital would submit data for every delivery in the performance period.
All right, I'm going to go to the chat and make sure I don't miss anything before I go to the hands raised that I see. Sindhu, you made a point in response to Christina about the coders. It seems pretty self-explanatory, but do you want to share? And then you can also respond with whatever your hand is raised about. You're on mute.
Sorry, the reliability, you would think we all figured that out by now. The reliability that was reported, that was so high in the evidence that was provided, was that was performed, I'm assuming, Elliot, based on what you said, after that extensive coding, education, and everything, or no?
It was not after extensive training and education on coding. It was sort of real life testing. I think one very important thing that wasn't mentioned so far is that there was reliability testing going back to each of the hospitals and testing whether the codes were present and real in each, both for the outcomes and for the codes used for risk adjustment. So that was performed in this setting.
You mean that the codes were checked with the chart, like that there was like, exactly. So that's what was interpreted as, to me, is it was reliable, where there was the code being present was consistent with what was determined based on chart.
Correct.
Evaluation. I think the coding issue is important because as you said, there's a lot of variation in, I think, how hospitals perform and how things are defined. If we're trying to create a standardized metric, the definition for these different pieces, both the outcome but also the risk adjustment, should be also consistent, or the metric, it's hard to kind of feel like the metric would be consistent. And so I know in the hospitals that the data in the 25 hospitals and the states that this testing was done in, that's true. But just as a point of comment for the developer, it would be good to actually think about sort of some standardization of definitions as well that goes along with this metric.
I think that's a great chicken and egg deal. I think to push that out nationally, you have to have a measure and a reason to have standardized codes, without for the obvious reasons.
I think that's come up now with the term newborn metric, where there's a lot of coding variation and there's a lot of I think that it's a chicken and the egg. But then I think when you put out the measure and there's inconsistency in it, it makes people upset about the measure and then makes the measure feel like it's less reliable. And so I think trying to sort of do that in parallel so that people feel good about the measure, I think is important as well as a measure if it's accepted.
Matt, I see your hand up.
Yeah, thanks so much. So I have two questions about the signal to noise reliability data that the measure developer provided. One is I'm a little confused on what's a pilot site versus what is, I guess, pilot hospitals. So if that could be sort of clarified, because my understanding is this measure is being specified at the hospital level. So I guess I'd like to just understand why data was provided for a different level of measurement. And then they provided data for both any severe obstetric complication and then with excluding blood transfusion only cases. And once again, just trying to clarify what measure is actually being proposed and therefore what reliability testing should we be evaluating.
Valerie, do you want to speak to the signal to noise?
Sure. Sorry, the question was about the number of sites. So for the number of sites, the initial, well, I guess, Chris will talk about the number of sites and the sites versus hospitals. But for signal to noise, the measure is being proposed to have two different outcomes. One outcome is all severe obstetric complications, and then a separate outcome is the same conditions with just excluding encounters that have blood transfusion only without any other severe sort of complications. So all of the results are presented for each of those outcomes separately.
Okay, so it's in a certain sense sort of a two-part measure. Is that correct?
Yes, there's two different versions of the outcome for the measure.
And so, okay, that's helpful. And then can you explain what's a pilot site versus a pilot hospital?
Sure. So our pilot hospitals are the individual hospitals, and then the pilot sites are the systems that the hospitals belong to. So we had individual, that's how it was broken down. So when we explained it in our review, so the health system is the pilot site, and then the individual hospital we refer to as hospital, just to kind of break down what we were looking at, either like a system level or an individual hospital.
Okay, and just thank you for that clarification. And just to clarify, this measure is being specified at the hospital level.
Correct.
So we wouldn't necessarily want to evaluate how it performs at a health system. We'd want to assess how it performs at the hospital level.
Correct.
Okay. Thank you.
Okay, any more comments or questions from the committee? All right, I want to clarify. Oops, I heard somebody say something.
This is Dr. Jalil here. I want to piggyback on what Matt asked, and I think it's still not clear about the measure, whether it is going to be split into two parts, A and B, or is it a single measure? Because when you look at the numerator statement, it says that it is combined those two, both the procedures and the complications, both are in the numerator statement. So can the measure developers clarify whether this is 1A and 1B, or is it a single measure?
This is Chris. It will be stratified. So both of the rates will be provided to the hospital, the overall rate, and it will be stratified to provide them their rate without cases where SMM was the only indicator of SMM.
Sorry, Chris, this is Katie Balstracy, one of the measure developers, where transfusion is the only indicator of,
yes, thank you.
Of SMM. Yes.
Thank you.
So this will allow hospitals to assess and CMS and the Joint Commission to assess hospitals both for any SMM or any severe obstetric complication as defined by the measure, both diagnoses, procedures, and the vital and lab signs that define the numerator, but also allow for assessment of the hospital when encounters that only hit the numerator because of a transfusion are removed. There is some question in the field about whether transfusion marks a severe obstetric complication, and so this allows for the assessment of both of those outcomes and isolates an outcome that excludes an only transfusion numerator event.
Okay, with that clarification, we're talking about scientific acceptability, and it must pass to go forward. So we're going to take the first part. And as I understand it, there's actually 2 votes to the first part. The first is that we're voting on accepting the Scientific Measurement Committee's reliability rating of moderate, or so that's a yes/no vote. And if we vote no, then there's a secondary vote where we as a committee vote. And again, we would be rating it as high, moderate, low, or insufficient. So is that clear? Okay, committee, then I'm going to ask NQF or Sean to put up the first vote for are we accepting the S&P's reliability rating of moderate?
Thank you, Kim, so much. So for measure 3687E, voting is now open on whether the committee accepts the Scientific Methods Panel's rating of moderate for reliability for measure 3687E. And your options are yes or no. And we're looking for 2 more votes. We are at 13 votes, so if anyone has any trouble accessing the Poll Everywhere voting link, please let NQF staff know and we will assist you on the back end. But just looking for 1 more vote.
Again, if you've successfully voted, your poll thing turned blue.
Correct. Thank you, Kim. And we are looking for one more vote. So if anyone has any trouble accessing the link or voting, please let NQF staff know. Okay, we are at 14 votes, so I will go ahead and lock the poll. So for measure 3687E on accepting the Scientific Methods Panel's rating of moderate for reliability, we have 14 votes for yes and 0 votes for no. Therefore, the committee accepts the SMP's rating of moderate for reliability. And Kim, I will turn it back over to you to facilitate the validity discussion.
Okay, so we covered some of that. Are there any issues that the committee would like to readdress or sort of make sure that it's brought back up to our attention, or some new comments? Okay, you guys have gotten quiet. I remember I'm
See Jennifer's
post-call.
hand. Sorry, I see Jennifer's hand raised.
Oh, I missed it. Thank you, Jennifer.
Thank you. So I think this goes under this section, but please from NQF, if you think it goes in another section, please let me know. I'm concerned at sort of macro level with this measure about combining lots of different maternal outcomes. And I do that based on a study that I and others published out of the MFMU, where hospitals rank differently if you looked at their individual maternal health outcomes, hemorrhage, seizure, those sorts of things. And so the question is lumping them all together in sort of a mixed media measure of maternal outcome really valid? Because you're getting a hodgepodge of measurement, right? You might be really good at hemorrhage and really bad at preeclampsia, and you get something sort of muddled in the middle. Are we better off constructing measures in general for maternal morbidity on the morbidity itself and not trying to combine them into one overall measure? The rankings based on the individual outcomes would suggest that they can't really be combined into one overall. So I'll stop there.
Christina.
Yeah, I was just gonna say, I think that's an excellent point. And I know at least for like AIM, there's like severe maternal morbidity from your hemorrhage cases and SMM from hypertension. And you could even like break that down even further potentially for the other common complications or the common morbidities and mortalities like sepsis and VTE. So I'm wondering, like, again, you know, it's a measure I use a lot in my hospitals, but we break it down a lot too. And proposing this overall measure that's not stratified by condition or race, ethnicity, or language, I think is such a catch-all. You know, maybe it's a good place to start, but I think there needs to be a plan of how it's going to continue to get refined. Because again, a hospital just doesn't know, are they getting better or worse because of something in particular?
I want to echo a point you made earlier too, that there are some conditions, specifically the Creta spectrum disorders, where the outcome hysterectomy is actually the planned therapeutic treatment. And so for some centers, that could be a problem. Sindhu? You're on mute.
I absolutely agree with Christina, you and Jen, what you both said. And at the same time, you know, it so sort of feels like for this, like perfect is the enemy of good. And so it sort of is like by the time we get to a place where we have like stratified like metrics that are or that are condition specific. And I guess that's partly my comment earlier of trying to, this should be the first step, right? Like you sort of identify these outcomes and then they get reviewed, and the processes that go into place that then would work to prevent them should also be measured. And I think that when these types of metrics get implemented, it's sort of as like this is the end game, is just like reporting these metrics, but hopefully that the way it's sort of rolled out is more as a sort of in that logic framework that the developer presented in their scientific background, which was around using this as a way to identify cases, because not even all of these cases we know will necessarily be morbidity. I think that the developer had good reliability, but we know that based on coding and other things that that's not going to be the case in real life when all hospitals start doing this. But the refinement, and it sounds like there's a plan to try to refine, but I don't disagree with you. I think that I think it's really hard to develop metrics that are condition specific and then roll them out in a consistent way with that, and try to actually make some progress sort of at the same time in sort of a fashion. I feel like we've been behind for a long time. And so that's what makes me feel like this seems like a good start. I think we brought up the coding issues, and I think it's a very good point. I think I did want to also just point out that, that ACOG has a committee opinion on measuring this topic. There's, the recommendation from that group is around, a combination of more than 4 units of transfusion and unanticipated ICU admission. Because at the same time, we also know, based, Kim, on what you said, that patients go to the ICU or get higher levels of care, which I know is not part of this metric, but that's actually a good thing. It's not necessarily, so you don't want to disincentivize good care. You don't want to disincentivize blood transfusions because people might get dinged for a blood transfusion when that's the right thing to do. So I think, all of these metrics have that balancing piece to consider.
So I have several hands up. I'm going to call on them in the order that they were received. So, Chris?
Yeah, I just wanted to clarify that the the numbers, the SOC numbers are really low. So to be able to show them in individual, like hemorrhage or hypertension, that would be difficult, and it's important to patients to be able to see the overall rates. The individual hospitals, though, will definitely be able to use the data to look at we have divided these codes into value sets that are broken out into the different morbidities, so that hospitals can use this data to look and see where they are better or where they need to focus their quality improvement efforts on. And I know Dr. Main has additional comments related to this, as well as Katie. We're kind of tag teaming on this one.
Jennifer, you're next. Do you want me to let them tag team or? Okay, go for it, Jennifer.
I was going to say, I'm always, I have a couple of rebuttals to both Sindhu and Chris. And so let me see what Elliot has to say, and then I'm sorry, the developer has to say, and we can kind of go from there.
Thanks, Jen. It is a balancing act. It is very hard to do a composite measure and with this low frequency and have the reliability. So when you break it into the sub pieces, you get below the reliability testing. I think our experience in California, where we have broken this down, we report it to the hospitals as measures and then allow them to see what proportion of it is related to hemorrhage, to hypertension, and so forth, has been really instructive for QI efforts. And we've uncovered that sepsis is a surprising high rate of issue in some of our hospitals, but not all. And that's allowed specific QI issues. And that's what the value sets that were just mentioned by Chris will allow hospitals to do. I think this is all about learning how to use the measure as we go forward. The ACOG bulletin that Sindhu mentioned is focused on identifying cases for QI review. They specifically said it was not, that those two items would not be useful as a measure, i.e. 4 units or ICU admission. And they cautioned in that bulletin that there was not, this was not a discussion of measure capability.
Katie?
Yes, I just want to echo what Chris Wallace said and also just speak to CMS planning, which is not finalized for an implementation of this measure, but very commonly what happens for hospitals reporting on a measure is they get a hospital-specific report. So not only do hospitals, in terms of an ECQM like this, feed the data in essentially and can identify their specific patients that way. But again, frequently CMS provides a hospital-specific report so that a hospital with a particular number of numerator cases will likely be able to identify exactly why each of those cases got into the numerator. So if it's a hospital that is doing quite well in managing hemorrhage, but is struggling perhaps with another of the obstetric complication outcomes for this measure, they will be able to note that. And that's an important piece of this, right? This measure is absolutely about supporting hospitals, about quality improvement, and about proving outcomes across hospitals. So they're not just going to get a number or a rating. They're going to get details that allow them to move practice and improve care.
Jennifer.
So let me address them in the order I think they came up. So to Dr. Srinivas's point, perfect being the enemy of good. I agree, except for this is really high stakes, right? This is potentially every hospital in America, every size, and the unintended consequences of these measures can be great. So they really have to meet a very high standard in my mind to pass NQF. I agree that I would love to see more research on this, more testing, whatever. I'm just not sure this is ready for prime time due to the construction issues that I mentioned. To Dr. Main's point about, the numbers get small. Well, that's because not every outcome is appropriate for measurement and a hospital comparison kind of way. VTE being the great example of that. When we looked at it in MFMU, we thought that was going to be one of the things we should risk adjust for and do. And the numbers were so vanishingly small that it wasn't possible to do. Either showing that the quality of care was good and this was essentially vanishingly small and not a target for improvement, or just that modern medical practice, this was a not enough that we could risk adjust on, and therefore is appropriate at the hospital level to review, but not at the national inter-hospital comparison level. So in my mind, I think the California Collaborative is clearly shown that, for example, hemorrhage is a perfect target for this, right? You can risk adjust, you can make a difference, you can save lives doing it. I would argue that hypertension is the same thing, but not everything in here is going to be perfect. The hospitals that, for example, take maternal congenital cardiac conditions and do well with them are going to be a handful. And to measure all hospitals in America on that, it is just on the onesie twosies, just doesn't make sense to me. So I'll stop there.
All right, I'm going to call attention to the fact that Matt has something in the chat. Do you want to say that, Matt?
Yeah, I was actually put something in the chat that actually sort of mirrored what Dr. Main had indicated. I was just sort of highlighting for the committee that, there's a trade-off with composites, right? And with these somewhat rarish events, the advantage of lumping them all together is you do improve the reliability of measurement, but it definitely comes with a trade-off in terms of understanding where the issues are, and maybe to some of Dr. Baylett's points, maybe we're lumping things together that shouldn't be lumped. I was more just pointing out from a measure construction standpoint the advantage of a composite.
Sindhu, your comments in the chat.
Yeah, I don't need to say anything else.
Okay. We want to try to say things so that it's recorded, but I got you. There was one thing I wanted to build on, and I can't remember right this minute. Oh, this is an NQF question, but I noticed that we're going to be talking later about a trial measure, and I just want to know conceptually, how is that different from, or why is that being called out differently?
This actually isn't a trial use measure. So the two this afternoon are, but this is for regular endorsement.
Right. So I guess I want to know, what does trial use mean?
Trial use doesn't have the data for testing for scientific acceptability. So they would gather that data through their trial use period.
Got it. Okay.
Kim, I'll just add a little bit more background on the trial use program. I know it's a little unique of a program here. This is Boonen from NQF. Approval for trial use is not endorsement. It is a different classification. And when a developer puts a submission in, they do indicate if they want to be considered for full endorsement or for approval for trial use. The concept behind approval for trial use, and this is only for ECQMs, is that this is a measure that the developer and if the committee agrees, thinks that this is good in concept and that there is evidence and meets all of our other criteria. However, in order to get the additional funding and support to test the measure, they do need a little bit more, trying to think of the right word, basically having NQF say, we think overall this is a good measure and should be further developed, would give them that a little bit more to get the measure fully developed. Sorry, I'm not doing a very good job of describing what I'm trying to say. Essentially, it's a statement of, in concept, we think this measure is good. Please go out, get it tested, and then come back with that testing information. They are not required to come back for testing, but it is only a temporary status for this approval for trial use. After 3 years, it is removed, and they do have to either come back for a full review or they will lose their status. Hopefully that provides a little bit more clarity.
That's actually very helpful. Thank you very much. Any other questions from the committee? Okay, this is another two-part vote. We're voting on the validity, and the S&P gave it a moderate rating. So our first vote will be, do we agree with that, yes or no? And if we say yes, we move on to feasibility. And if we say no, then we do a separate vote on validity where we score it high, moderate, low, or insufficient. So Sean, take it away.
I'll jump in here. Sorry, I didn't get a chance to even let you know, Kim. Sue Kendig messaged us that she had to step off the call for an hour. So the team is doing a double check right now, but I believe we have lost quorum. I think we're at 13 and we need 14. Let me just confirm in the chat as we look. But that means that we'll actually have to proceed with offline voting for the remainder of the day, which means we'll continue with discussion through each criterion as planned, but we won't be taking live votes on the call. Instead, we will send the committee the recording of the full meeting and a SurveyMonkey link to record all your votes following this call. It probably takes about 24 to 48 hours to get that to you. We have had to do this already this cycle with another project, and so my advice to you from that committee would be to record how you would vote as you go along, so that when we send you that survey, you don't have to refresh yourself on the discussions. You've made notes as each discussion happens, and that will make filling out that survey a lot smoother for those who are present today. And obviously the rest of the committee will need to listen to this recording. And I see in the chat, can't we vote for those of us who are here? Unfortunately, we can't use that. We use two different platforms for live and offline voting. And so just to ensure that we've accurately captured the votes and there's no duplicates in voting, we have to have all the votes recorded in one system. It looks like Matt has a question, I'm guessing, for me.
I do, Tammy. Quick question. Because this validity vote is actually sort of a conditional vote, we're first voting on whether or not we agree or disagree with the SNP's recommendation. Are we going to be voting on both questions? Because we don't know how the first question is going to turn out. If we vote no, then we will have needed to have voted on the second question. But if we vote yes, then we don't need the second question. So how will we handle that?
Right. Exactly. So because we won't know the outcome of the first vote, you'll actually just take a regular vote on validity now when you're offline. So it will be a high, moderate, low, insufficient vote for validity. But keep in mind that were we live, the SMP did pass this measure with a rating of moderate. And so how would you have voted live? And then you'll need to decide if you would give this a high, moderate, low, or insufficient rating when you actually make your vote. So
Okay.
there'll just be one vote on validity offline.
Okay.
Is it possible for NQF to send us sort of a list of a Word document or something of the votes so we can easily keep track of which was which on our own notes? Because it's very hard to take a note, say what you would say, and get the question exactly right so you can match them up later.
Absolutely. So what we have done that we, in the past that's worked, is we will announce the vote options after each discussion before you move to the next criterion. So you won't be live voting, but we'll state out the question and what the vote options are so that you can record whether it's a high, moderate, low, or a pass, no pass, or a yes, no vote, so that it's easier for you to follow along.
Yeah, I guess what I'm asking is, can we have that written, the questions written and the yes, no, so we can just take notes rather than having to record the question ourselves?
We don't have a written version of it. Unfortunately, we expected to have quorum throughout the meeting, so so this is an unexpected change, and we'll have to send that survey link following the meeting.
Well, that brings us to the feasibility discussion. The preliminary rating was moderate. Sindhu, do you have any comments to add?
So the feasibility is meant to, is the extent to which the specifications, including the logic, require data that are readily available or could be captured without undue burden and can be implemented. And so I think we heard, and it was clarified earlier, that this is meant to be not a sampled measure, but all deliveries in the time period that would be requested, that the risk adjustment would be done centrally, but that all hospitals would have to submit all of their delivery data and all the other aspects that were requested in terms of the risk adjustment. From what I recall from the testing that was presented to us, there was a few different electronic systems that were included in the hospitals that were part of the sample. I think Cerner, Epic, and one other. And so it was tested in that sample from the pilot sites and the hospitals. The sort of, there were some other aspects of feasibility for some data elements that were looked at, including sort of for some of the procedural aspects of the outcome measure. And there was a couple of areas that pilot sites were unable to accurately capture that I think are just worth mentioning. One was the timestamp for the procedure performed and a laboratory test, the PaO2 to FiO2 ratio. Based on that, the draft specifications were revised, and then the feasibility score on the revised specifications was improved to 98% based on the sites that piloted this. And as you said, the preliminary rating for feasibility was moderate.
So unfortunately, Sue was our second presenter. So does anyone else on the committee have any concerns or questions or comments about feasibility? I guess I would want to ask, what are they using the date and time stamps for? Like how is that informing the measure?
This is Chris. Actually, I'm going to call on Marilyn, who is our ECQM specialist, and she can explain the timestamps. Marilyn, are you able to unmute yourself?
I can say from personal experience, we've been working on that for a VTE measure, and it's interesting because it goes back to documentation and workflow, and it's a challenge.
It does, and we do use timestamps sometimes for the logic in order to capture when something was documented if it's used in the logic. However, one of the timestamps that was problematic, it was removed. And that PaO2, as she mentioned, that was removed from the measure as well, so that it would not cause problems in the future.
So by removing it, you took it out because you didn't feel it was
Because it
valid.
didn't, well, if it's not used in the logic, then it's not needed. And there was one timestamp that actually was not found. It was the element that was not generally used with a timestamp. And so that's why we updated our measure to match what was found in the EHR.
Any other comments from the committee? Okay, I'm going to ask NQF to direct us on what the question is that we would be voting for that we should be writing down.
Sure, Kim, thank you. So this is the question on feasibility for measure 3687E. The question is locks, as we did lose voting quorums, but as Kim stated, to aid everyone in their vote, feasibility for 3687E, your choices are high, moderate, low, and insufficient.
And for our own understanding, can you go back to the beginning where you explained how this would be interpreted for consensus?
Do you mean with the voting totals?
Yeah, well, you said something earlier about the evaluation so that we understand.
I'll answer what I think you're asking, but tell me if this is not getting to your point. So passing votes on feasibility are considered a high vote or a moderate vote. And more than 60% of the committee must vote high or moderate for this measure to pass on feasibility. Low and insufficient are considered not passing votes.
That is helpful. And yes, that was what I was asking. Thank you very much. Okay, everyone. Thank you very much. This is not as fun when you can't see the scoring, but we will keep going. We're now going to talk about usability and use. This is a pass, no pass vote. The staff preliminary rating was pass. Sindhu, would you like to present here?
Sure. So again, use evaluates the extent to which audiences, both consumers, providers, policymakers, use or could use performance results for accountability and performance improvement activities. And then performance results are used in at least one accountability application within 3 years after initial endorsement and are publicly reported within 6 years. This measure now is used in the ORIX performance measure reporting, the HAP and critical access hospital accreditation program, and it's implemented by the Joint Commission. And these programs also provide quality improvement data with internal and external benchmarking. So I'll stop there.
Does anyone have anything to add or questions or comments? Ugh. Computer keeps timing out, but it's giving me my prompts. I'm sorry.
This is Dr. Jalil here. Sindhu mentioned 3 of the organizations. I'm not familiar with those organizations. Can somebody clarify how big these organizations are and how many hospitals are using this?
This is
Sorry. Go ahead, Dr. Main.
This is Elliot Main again. We have been using a version of this that is exactly the CDC version without the vital sign and without the laboratory value addition for some 3 years, and that's 300 hospitals and about 600,000 annual births. And it has been very useful, and there not have been the negative consequences that that have been worried about from using this as a benchmarking and quality improvement tool. It's been widely accepted. Back to you, Chris, for the other applications.
Thanks. So the Joint Commission has offered EPC07 as an optional measure for reporting year 2022. So we have not received data yet, but we do have organizations that have implemented the measure, and we have provided information on our measure through the webinar to help with implementation. As far as the pilot testing goes, it was a total of 10 pilot sites and 28 hospitals that were included in some phase of the pilot testing. So you've got Dr. Main's CMQCC data that's comparable. You've got our pilot testing data, and then we have already implemented it for the Joint Commission as an optional measure to get early adopters in on this measure for their ORICS requirements.
Thank you.
Okay, any other comments? All right, so this is a pass, no pass vote. So if we pass it, we then have a second vote on usability. Should we save that discussion next, or how does that work?
Yep, they're separate discussions, so
Okay.
they're unrelated. Yep. Do you want Sean to put the options up for everyone?
Yes,
to see?
please.
Okay.
So for measure 3687E on use, your options are pass or no pass.
I think we're seeing the slides. Yeah.
Oh, apologies. Technology is not perfect, no matter how much they say it is. So for measure 3687E on use, your options are pass and no pass.
And then for usability, Sindhu?
For usability, it's really about sort of the extent to which it could be used. So performance results could be used for both accountability and for performance improvement activities. This is where I think some of the potential harms that I mentioned earlier, I know Elliot just said that in their use, they haven't seen this, but this was brought up in the comments by some of the, in the data that we received, that, that hospital resources could be shifted towards supporting this type of data extraction and reporting, and that might be an unintended consequence towards QI work in general. And also having hospitals focus on complications in the measure while dismissing other complications. So the, I guess, concept that Jennifer was bringing up earlier about just, while you're combining everything into a composite, are you sort of straying away from focusing on some of the complications that matter the most? Although Elliot also brought up that hospitals were identified as having sepsis as a more of a problem than they thought, which I think is one of the benefits of a measure like this, where different hospitals might have different areas of improvement that might be, but that might need to be tackled, and a composite helps you figure that out. So I think there's a balance of this measure that we can use. The one comment that I'll make, and I don't know if this goes into usability, and if it doesn't, and the preliminary rating for usability was high, is just in how some of these metrics are used, in terms of their public use versus their use sort of within hospitals to provide data. And really, when it's used in sort of ways that there's certain ways of use that could lead to dismissing of certain things, or basically inappropriate documentation, or basically trying to, get around the metric. And I guess I don't know that it's more of a comment that I want to make around usability in terms of bringing up the fact that we want the metric as it's been developed and stated is to provide important quality improvement areas for hospitals to improve and improve maternal outcomes. And I guess in terms of how it's used when it eventually, if it gets rolled out, it's something that the developer should consider in terms of preventing misuse of metrics like this to disincentivize quality improvement.
Any other comments from our committee? I want to particularly reach out to those who have not yet spoken. Okay, well, then let's look at what the vote should be. On usability, it's high, moderate, low, or insufficient. And the preliminary rating was high.
Correct, Kim. Thank you. So for usability for measure 3687E, your options are A, high, B, moderate, low, C, low, or D, insufficient for usability.
And now we come to what should be the exciting drum roll, overall suitability for endorsement. And this is a yes/no vote. Before voting, I'm going to ask if there are any other comments or questions from the committee. And again, want to invite our quieter participants.
I think Christina has her hand up.
Oh, I missed it. Thank you. Hi, Christina.
I'm definitely not one of the quieter participants, but I'll raise my hand anyway. Again, based off of everything that we've talked about, I do agree that overall this is an important measure. I just am concerned about hospitals that may be doing this for the first time, because there's so much that those of us who've been doing it for a while have learned. And I don't know, I'm wondering, is there a conditional vote? Is there a way to say, like, we've talked about a lot of things that we think are important, but then the vote comes down to a very black or white yes or no. And how is the rest of this information going to get incorporated into this measure in terms of, like, I think it's irresponsible of us to put out this measure without stratifying by race and ethnicity from the get-go. And, even though that is something that is being discussed or under development, what kind of information are hospitals going to get in terms of, okay, someone may have never done this before, never looked at this before, and now all of a sudden they have to start reporting on it. And that's what concerns me, is just, people not having this kind of background baseline level of understanding of how to do this and what to do with the information. And maybe some of the lack of these, you know, unintended consequences at other hospitals is because it's being done in a system that's like, you know, CMQCC, where you've got all of these toolkits and webinars and things like that. But, you know, some rural hospital that just all of a sudden has to start reporting this and hasn't been involved in all of these statewide QI projects potentially, you know, what is that going to do for those hospitals? So that's what I'm concerned, is that we're voting on a measure without thinking through all of the potential next steps or even a toolkit for implementation. That's all.
So I see a comment in the chat that that's a fair statement from Sindhu.
That was an error.
Oh.
There are a couple of hands raised.
Please, I don't see any. Oh yeah, I see Dr. Rajan. You're on mute, sir.
You're
Sorry.
on mute, Rajan.
I am so sorry. This is Dr. Raj Radhavan. I have the same concerns that Christina shared about applicability in small hospitals. Also, the variation in this rate from year to year, if you're a small delivery hospital, also makes me a little worried about the measure. What would that do, since some of these are fortunately infrequent events? And then all the other things that we talked about, including if you're in a CRETA hospital, how do you account for that, where the hysterectomies are intended and planned for those deliveries?
Chris.
Thank you. So we just wanted to clarify that this measure will be stratified by race and ethnicity. It is in the planning phase for CMS. Joint Commission will determine how it is broken up once we see the data to make sure that we are able to, you know, display the different, you know, how we need to display the different race and ethnicities. The measure will definitely be stratified by race and ethnicity, though, by the time data is presented. Hospitals will also have this ability to look at their own individual hospital data with race and ethnicity as well. So even if that is a little separate way than the volume requirements that would be for public reporting. So currently the volumes in the development testing data are too low between hospital comparisons, but national reporting should offer sufficient volumes to do this. So we are planning, this will be, you know, we think that's an important piece of this measure as well, to look at the results and stratify by race and ethnicity. Another thing we wanted to mention is that, you know, getting hospitals on board, you know, we do education on how to implement the measures, on the measures. When we get feedback, we have a Q&A feedback system that we monitor questions on measures and how to implement and abstract and do all these different things with measures, and we answer those questions within 8 hours, and we work with hospitals to help them with those questions to make sure that they're implementing the measure with less burden. We also take the feedback that we get, and we you know, provide information in future webinars to make sure that these issues are addressed nationwide, to make sure that others are not having any difficulties or the same questions, to really support implementation of any measure in a Joint Commission perinatal care measure set. I know CMQCC also does a lot of education for their hospitals as well as other collaboratives, and we also provide webinars based on our measures to those collaboratives. So there's a lot of outreach to help support hospitals implement these measures. And, you know, this is an ECQM, so, you know, it's coding. And so those codes are going to come over and really provide the data for the organization. And we found it to be the organizations that implemented during the pilot test and was definitely feasible to do.
Dr. Jalil, you had your hand up. Did you want to speak? Okay, great. If you,
sorry, I think Chris Wallace did answer my questions. So I put my hand down, but so I'm reassured that Joint Commission is looking into this, asking for feedback and soliciting feedback and trying to improve that. I have a question for NQF though. Once this is endorsed, how long is this endorsement valid for, and when are we going to review this for maintenance and re-endorsement?
The typical maintenance review cycle is 3 years. That can be different for a variety of reasons, including if there's a change in the specifications as part of a yearly update that warrants the committee looking at the measure sooner. An earlier review can happen, or if there's an unintended consequence of the measure that a member of the public brings forth that warrants an early review, that can happen as well. But standard maintenance is every 3 years for an endorsed measure.
Valerie?
Thanks. Just to address the comment about the variation from year to year. So while hospitals will receive their observed rates back to them, so they can monitor their changes in any observed outcomes, both the composite and individual from year to year, the risk standardized score is recalculated every year, given the makeup of the risk factors in the population that was submitted for a given year. So the risk standardized scores are best compared across hospitals within a given year.
Okay, so I'm going to call for a vote, hearing no further comments. We are voting on overall suitability for endorsement, and this is a yes or no vote.
Correct. As Kim mentioned, this is for overall suitability for endorsement on measure 3687E, and your options are yes or no.
Kim, are we actually voting now, or do we have a quorum again?
No, Martha, we lost quorum, so we will be sending a recording of the meeting along with an offline voting survey. Just putting the questions up to help folks.
Great. That's what I thought. Thank you.
Write down their answers. You're welcome.
All right, everyone, I want to thank you for a very healthy discussion, and I'm now going to turn it over to Martha. And I actually need to relocate offices, so I'll be offline for about 5 or 10 minutes.
Hi. So I've got a question for the NQF staff. Do you want to take a short break or plow ahead?
I'll direct that question back to you. Our lunch break is scheduled for noon. We typically take a 30-minute break, and then we do have a brief afternoon break. So you're right, it would likely fall in the middle of this discussion. So we can either pause at noon regardless and then reconvene, or we can take our lunch early and then plan to do this measure along with the last two following that break. Is there a preference on the committee?
Plow through.
I'm good to plow through unless somebody desperately needs a break.
Why don't we do that? And at noon, if we're close to being through the discussion, at noon we could discuss delaying for 5 or 10 minutes to finish, or we could just pause at noon and reconvene in 30 minutes.
Great.
Okay.
Okay. So we are now going to discuss NQF 0471E, which is an EPOC02 cesarean birth measure, a new measure. This measure assesses the number of nulliparous women with a term singleton baby in vertex position delivered by cesarean birth. It's an outcome measure. It's measured at the facility level, inpatient hospital facility, and the source is EHR records or electronic health records. It looks like there are no recusals and we need 15 members to vote. We're still short one, I believe at this point, but maybe by the time we get to voting, we'll be able to go ahead and vote.
Actually, once we lose quorum, we just proceed offline the rest of the day. So, so numbers are better for a good discussion, but we'll be doing offline voting for the rest of the afternoon.
I see. Okay. Hang on 1 second. I'm on a laptop, so it's a little clunky here. Chris, from the Joint Commission, would you like to give us an overview of the measure?
Yes, thank you. Thank you for allowing us to speak again, this time about our cesarean birth measure. Although cesarean delivery can be life-saving for the fetus, the mother, and both in certain cases, the rapid increase in the rate of cesarean births without evidence of decreases in maternal or neonatal morbidity or mortality raises significant concern that cesarean birth delivery is overused. The cesarean birth measure looks at the NTSB cesarean rate, which is a primary cesarean in first births with term singleton pregnancies in a head-down position. This is an important population to focus on because nulliparous women have 4 to 6 times the cesarean birth rate than multiparous women, and therefore the NTSB population is the largest driver of the primary cesarean birth rate. In addition, a reduction in primary cesareans will reduce the number of women who have repeat C-sections, as almost 90% of mothers who have a primary C-section will have subsequent cesarean births. Studies have shown an increased risk of severe maternal morbidities for cesarean delivery compared to vaginal delivery. Layla et al. 2022 conducted a retrospective case control study of all births in a nationwide inpatient sample between 2005 and 2014 in the United States. Results showed that relative to unassisted vaginal delivery, adjusted logistic regression analysis reveals no excess mortality observed with assisted vaginal delivery. However, adjusting for demographic and obstetrical confounders, a significant risk of maternal mortality was observed with cesarean delivery. This risk was more pronounced amongst primary cesarean deliveries. Therefore, it is important for healthcare providers to understand the short-term and long-term trade-offs between cesarean and vaginal delivery, as well as the safe and appropriate opportunities to prevent overuse of cesarean delivery, particularly primary cesarean delivery. A safe reduction in the number of NTSB patients delivering by cesarean birth will result in increased patient safety, a decrease in SMM and neonatal morbidity, and savings in healthcare costs. The cesarean birth measure can assist organizations in monitoring their quality improvement efforts to reduce the NTSB cesarean rate. We developed the ECQM version of the cesarean birth measure to reduce administrative burden for sites able to report it and to encourage the use of ECQMs. 13 Joint Commission accredited hospitals submitted PCO2 data for both the ECQM and chart abstracted measures in calendar year 2020. The EPCO2 rates for the 13 hospitals who submitted both ECQM and chart abstracted measure results to the Joint Commission for 2020 discharges were correlated at 0.88, which is strong and is statistically significant. The ECQM data for this correlation came from 2 EHR systems, Epic and Meditech, and the Joint Commission accepts either ECQM or chart abstracted data or both for the Joint Commission accreditation programs. Thank you.
Thank you, Chris. I think we now go to our lead discussant number 1, that's Amy Bell. Who will give us your overall thoughts.
Good afternoon or good morning. This is Amy, and looking at this measure, I think we've all are used to this measure for not the E version, but the regular version. So we've been collecting this information for years. I think from the evidence perspective, we have evidence that really does show that we have an opportunity to close gaps in care, and there's a lot of variation in practice and a lot of variation in the rates that are giving us varied outcomes. I think we have from the lit searches that were very well done. I think there is evidence to support that this measure continue in the E version. I will ask other discussants if there's anything they would like to add to that.
Diana, do you have anything to add?
I don't. Thank you to Chris Wallace and to Dr. Bell.
Then Jaleel?
Yeah, I don't either. Thank you.
Okay, so we're in a little bit unfamiliar territory here since we're not going to vote. I think that the next section will be that we first look at the evidence, which we will be voting on later, and it's a pass, no pass. So do the lead discussants have anything that they want to comment on in terms of the strength of the evidence on this measure?
I could just reiterate what Chris Wallace already said, that the importance to measure and the evidence passes its very strong practice gap with measurable disparities in every category that we can quantify disparity. It's an outcome measure and its importance is high.
Other comments on evidence? Okay, Sean, am I ready to go ahead and show the question that we will be voting on?
Absolutely, Martha. Thank you. Let me just pull that up here. So for measure 0471E, importance to measure and report, 1A evidence, your options are pass or do not pass on evidence for measure 0471E.
Okay, great. Thank you, Sean.
Thank you, Martha.
Let's move on to the performance gap. We will be taking a vote on that. Do our discussants have anything to say on that one?
There continues to be a large gap, even though we've been working on this measure for years. You know, it goes from you know, all the way up to 70, almost 72% rate, and it's, you know, it does vary from facility to facility and region to region. So the gap in performance is still very much present.
Great, thank you. Any other comments on performance gap? All right, Sean, will you show us what we're voting on?
Of course, Martha. Thank you. So for measure 0471E, importance to measure and report performance gap, your options are high, moderate, low, and insufficient.
Okay, thank you. And I want to note that the staff preliminary rating was high on this question. All right, now we move to scientific acceptability. The scientific methods panel preliminary rating was that they did not reach consensus. So I think we have a little discussion here. Will one of our discussants lead this
I think
conversation?
that it's noted that the specifications are very clear and concise. They're meeting the latest industry specification standards. There was an inability to achieve a conclusive rating out of the SMP. However, reliability and validity testing was conducted with 96.5 to 97.7% validity, demonstrated with a sensitivity of 73.7%.
Diana, what was the what was the basis for the non-consensus vote on this one?
I would have to defer to the SMP experts because it was specifically related to the e-measure functionality, not to the NTSV metric itself. But is there an expert who can summarize the concerns by SMP?
Hi, this is Tammy from NQF. I can summarize the rationale for the consensus not reached vote. The SMP stated that the developer relies upon validity testing to demonstrate reliability in this instance, and that the approach to testing was correct. However, the results raised reliability concerns. So the overall agreement rate was the same as the kappa adjusted agreement rate, and the results were seen as implausible because the agreement rates were identical to the kappa results, which raised questions about the validity of those results. The SMP did not find any issues with data element capture or reliability otherwise.
Any other comments or questions? We're first entertaining reliability, for which there was, and then we'll move on to validity, which again, there was no consensus. So let's do reliability first. Questions, comments?
Dr.
I
Davidson.
see Christina Davidson's hand. I don't know if you can see hands.
Oh, I couldn't see that. Thank you very much for your help. And then I see Matt. So go ahead, Christina, please first.
I'm not 100% certain of this from personal experience, but I have heard that there is not a code for parity, an ICD code. And so is that true? And how do we confirm this is accurately being measured only when it's only done electronically?
This is Chris. Would you like me to answer now or wait for the others with the hands raised?
Let's go ahead and take that question.
Okay, so so yes, there are some data elements that are used, and what happened here. So the Gravida and Para is documented in the EHR systems, and that is what is used. And we also that is what is used as the in the measure logic. So the overall kappa levels for the two sites were due to there was 10 specific data elements, and there's data elements that we use in other ECQMs. The data elements are shared with EPCO7. So, and they had excellent match rates. And these data elements were related to the estimated gestational age and also the preterm and term and the parity results. So we are confident that these data elements are able to be pulled, and there was a 91.2% match rate at site 2 and 100% at site 1 for these data elements. So while we don't use codes for that, these are data elements that are seen in the EHR and that are accessible to be pulled into the ECQM logic.
Martha, I see Matt Austin's hand up still as well.
Yeah, thanks. So I'm reviewing some of the information that was submitted as part of the application. And it looked like there were two sites where the data elements were reviewed. It looks like at site 2, it was lower than site 1. And there was some mention that site 2 uses a standalone OB documentation system that didn't completely interface with Meditech. And so I guess my question or concern that gets raised by that is, do we know how widespread that potential issue is? I mean, it was found in one of the 2 sites. And there was mention that there's sort of a mitigation plan put in place for site 2, but how do you ensure that there aren't issues at many other sites, and how would you sort of address that there's a potential sort of data issues?
Sure, this is Chris. I can answer that. So that is correct. So there were some missing data for that site too, because they used a standalone OB system that did not completely interface with the electronic health record, which was Meditech. And the OB documentation was in Meditech, but in non-discrete fields in a PDF format. That's how they had planned their, how they would integrate. So after learning that they would need these fields, they were able to integrate their data, and we checked back with them. We weren't able to submit any additional data to support, to update our findings, but we did meet with them and their vendor, and they were able to, they walked us through a couple of charts and what they provided data to their vendor for, and these fields are now interoperable. They are pulling into their report for their measure, and they're working with their staff to educate on the new fields to make sure that these are where the documentation will take place. So we did verify with the site. We also spoke with the vendor, and they said that other sites that have this will either they've recommended to integrate the way this organization has, but she said that some sites are just documenting the additional fields in their other system to make sure that they're pulling into their reports. So different hospitals handle it different ways. This hospital decided to make the full integration so that they could use the ECQM version.
If I may add,
Go ahead.
This is a measure that already has a non-ECQM version that is used by all hospitals that are Joint Commission members. And that allows for the ability to compare and contrast what you're getting in your first pass on the ECQM with what you're getting on the standard non-ECQM version, and then can address discrepancies in your system. So it has a built-in comparison group for the initial year or two.
Is there a requirement that hospitals do that comparison, or are we sort of assuming that they may want to do that? I'm just a little concerned that if you found data issues in 1 out of 2 sites, how do we know that the data issues aren't more widespread across the United States? And I guess that's what has me a bit concerned about this measure.
Jalil, I think you had a question.
I was piggybacking on what Matt had mentioned, but I was planning to bring this in use and usability because I think it's relevant over there more than invalidity as well. But I think it's important here too. The site 1, as I understand, there were 6 hospitals within site 1, and site 2 was just 1 hospital. And all the hospitals in site 1 had EPIC as the electronic health record documentation, whereas the other site 2, which is 1 hospital, had Meditech. Is there I understand that this is a pilot, and so there is limitations for that. Is there a reason why these 2 sites were chosen, and the rationale between site 1 having 6 hospitals versus site 2 having just 1 hospital?
Sure, this is Chris. So we used these hospitals because they were generous enough to volunteer during a time of COVID and, had the resources to do that. So it just so happened that the one pilot site had 6 hospitals that were willing to participate, and that the other site was a smaller hospital that wanted to participate and be able to report their ECQM data. So as far as the systems, so it's not that the EHR, so Meditech does have these fields. They are able to be pulled into the report for an ECQM. Epic, obviously, as you saw, had great results as that as well. In PCO7, these data elements that were problematic for site 1, Meditech was also checked, and they had excellent reporting out of Meditech. The issue is that it's the separation that they use, Meditech, and then they use like another OB documentation system. That OB documentation system actually has these fields as well in and could report out of that as well, but it's not combined with their other documentation system for postpartum. So these hospitals use separate documentation systems for delivery versus postpartum. So to combine them, that is something that the hospital would have to do to make a decision how we're going to get that data. Initially, this hospital was just sending their PDF reports over to their Meditech, so it was all in one place, which is fine. Chart abstraction, go ahead and do that. Now they want to report the ECQM data. The ECQM, the fields are there. They just need to link them to the other documentation system. So both documentation systems do have these fields. It was just where they were pulling the report from. They needed to make sure that the report is pulling from the fields that they are using, since they use a separate system. This hospital has solved that problem. Other hospitals, we were told, do document in both systems for certain areas to make sure that those data elements are being pulled in for reporting purposes, or that the hospital has them in one spot for the postpartum nurses and doctors to view instead of going to a separate system. And again, going back to the Joint Commission, providing feedback and support to those that are helping or those that are reporting our ECQM data. When we give webinars, this is a lesson learned that this organization had that issue, and we will be addressing that in future webinars to make sure that if organizations do have a separate system, what is their plan to be able to implement the ECQM data appropriately. And there are different ways that they can do that based on hospital resources and what they want to do. But that's something that we'll highlight to make sure that organizations are considering that.
Okay, let's see. I think that we should probably finish up our discussion on reliability and then break for lunch and go back to validity. I think some of what we've been discussing kind of goes into the usability discussion, but there's some overlap, and I think that was appropriate. So are there other comments just on the vote on reliability? SMP, by the way, did say there weren't any issues with data element capture or reliability. There were these questions we've just discussed. But it sounds like there's good thinking and a corrective process in place. Also posit that having worked with records, that till a requirement that the data be usable, then there isn't a lot of incentive for the EHRs to make that happen. And so, as I think Dr. Main had pointed out earlier, it's kind of a chicken and egg thing. That's just my personal opinion on this one. Any other comments on reliability? Sean, do you want to show us what that vote's going to look like?
Will do, Martha. Thank you so much. So for measure 0471E, scientific acceptability, reliability, your choices are A for moderate, B low, and D insufficient. Just a quick note, there is no high choice due to the level of testing conducted within reliability testing around patient level data. So the highest option is moderate.
Okay, great. Thank you for that. I think it's noon or whatever time it is, wherever you are, but it's the top of the hour. And I think we should go ahead and take our 30-minute break. And please all come back, reconvene in 30 minutes, and we will continue with a discussion on validity on the cesarean, the EQM for cesarean birth.
Okay, we'll see everyone at 12:30 p.m. Eastern Time.
Good morning.
Hey, it's Amanda. I'm in the car and I will be home, settled, on monitor, etc. in about 5 minutes.
No
but
worries.
But I'm
No
paying
worries.
attention.
Okay, thank you. You got a new do going there, Chris. I know. I didn't wash my hair, so it was kind of like, what the hell can I do with it?
Figured I would do mine tonight before the game starts.
Are you going?
Not tonight, but I'm going to the All-Star game though.
You are?
Yeah.
Oh, that's fun. That's very cool.
Yeah, I'm really excited.
Oh yeah.
My husband's splitting the ticket. He's taking my daughter to the home run derby, and I'm going to go to the All-Star game. So
nice.
I'm very excited.
I don't know if I can stand having two baseball fanatics on the call at once.
Dr. Main, I'm not sure if you're aware, but you're not muted on, I'm not sure, are we hearing conversation from your computer or this discussion amongst the committee?
All right. All right. So we were reviewing NQF 0471E, PCO2 cesarean birth. And we had gotten through the scientific acceptability section on reliability, and we now need to discuss the information presented on validity. Just as background, there was also a consensus not reached by the SMP on validity, and I would like one of our discussants to enlighten us as to the causes and any concerns you might have on that.
I think, I'm sorry, I think we covered this earlier because the testing on reliability hadn't been finished, but there were 7 hospitals tested. The validity ranged, the results were between 96.5% and 97.7% with a sensitivity of 73.7. And I think that we reviewed why the SMP couldn't achieve consensus in the last discussion. And I would just reiterate what Dr. Mean said earlier, that this is the E measure and that the NTSV measurement construct has been demonstrated to be reliable and valid. Not to cross conversations, but.
No, thanks, Diana. Any other comments or questions? Okay, Sean, would you please show us the vote that we're going to be taking?
I'd be happy to, Martha. Thank you. So for measure 0471E in scientific acceptability on validity, your options are moderate, low, and insufficient.
Thank you, Sean. Yeah, I'm writing this down as I go along so that as suggested, it'll be easy to fill out the voting form once available to us. So you see me taking notes on the side. That's what I'm doing.
Thank you, Martha, so much.
All right, let's move on to feasibility. Do we have a discussion to guide us through that? Amy, are you on for that?
Yes, I am on. So for feasibility, I think similar to what we've talked about before regarding the measure that's the NTSB measure that is not the E measure. No issues with feasibility on that one. With this one though, with the E measure, data elements are collected by healthcare providers that are actually providing care for the patient, and then also through coding. I think there was some issues with, talking about Meditech and the other EHR systems that could actually also impact the feasibility of it, in addition to the validity. And that's just one thing just to kind of bring up here as well, even though I don't think it was specifically mentioned, but they were, questions for the committee around just EHR concerns with this. So wanted to open that up and see if there's any questions or if any of the other lead discussants have anything to add with that. And then the preliminary rating for feasibility was rated as moderate from the committee, so, or from the panel, just as an FYI.
Okay, Amy, thank you. Any questions from the team here? Oh, I see, Christina, thank you. I see your hand raised.
Not sure where the best place is to ask this question, but so now is not the time to answer it. That's fine. But one of my concerns about this measure has always been that it doesn't exclude some things that are legitimate and indications for a primary cesarean, regardless of parity. And so I've always been concerned about that from a standpoint of even things like umbilical cord prolapse or HIV with a high viral load or an active herpes outbreak or a history of a myomectomy or a placenta previa or a vasa previa. So where is it appropriate to talk about some of the things in this measure that really should be reasons to do in NTSV or cesarean and even a multiparous patient? And then also, is this measure also being stratified by race and ethnicity? And I think it should be.
I think that's a question for the developer. I'm gonna hazard something here though for expectation that you're going to have 0 cesarean sections. So those situations that you mentioned would fall into that expected C-section rate. I think it's still unclear what the goal should be, but the way the measure is designed, it seems that it captures or allows for those situations to be adequately captured. But I would like to turn to the developer if you've got more information on that.
This is Chris. So as far as the race and ethnicity stratification, we do collect race and ethnicity data on all our measures, and we would consider stratifying by race and ethnicity in the future. However, hospitals will be able to use the data to do that for their internal hospital. But as far as hospital comparison, we do plan on looking at that for our measures in the future. Again, it has to be with sufficient volumes to be able to present that data. But definitely hospitals themselves can look at the data currently with their race and ethnicity data that they submit. And then as far as the other implications for cesarean birth, Martha, you're exactly right that these conditions, while they're known to be for reasons for cesarean birth, this measure is just we want to keep that focus on the population, and the measure itself. On our specifications, we have updated it to, instead of say lower is better, that it should be within optimal range, because we don't know what the low level cesarean birth rate is that is safe. And so we don't want to inappropriately encourage hospitals to continually lower their C-section rates into a unsafe area. So we use appropriate rate, and at the Joint Commission we use less than 30 because it is not risk adjusted. And we know that hospitals should be able to maintain a rate less than or equal to 30%, but that we don't report rates that are below that, because we don't want hospitals to be comparing and competing to try to lower their rate just because the hospital next door has a rate 2 percentage points higher. So we don't want people to compete to lower the rate. We want to lower the rate for to lower the overall rate of C-sections. And so this is that primary group that if you lower the rate in this population, you're going to see lower rates in the overall rate, because there's going to be hopefully less placental abnormalities in the future, less VBAC or repeat cesarean births in the future. So the purpose and the intent of the measure is to really just hone in on this population and not focus on reasons why someone would have a cesarean birth rate or a cesarean birth, because of course there are situations that would require a cesarean section. So, but again, that's why this is not a low rate measure, and why we carefully word our ideal C-section rate in our measure information forms and try to not allow for inappropriate comparisons.
Thank you for the explanation, Chris. Kim, I saw your hand, and then Sindhu. And if there are more hands, please tell me because I don't see them. Go ahead, Kim.
I'm going to have a little bit of flight of ideas and keep me on the right track. But a couple things is that the 30% is new, that a lot of people are still striving for that 23.9. So, and so it begs the question about harmonization that we need to think about with other people using this measure. The point about the exclusions, I think it just has to make clinical sense. As someone who's been doing this for, I feel like 30 years, but at least the last 15, clinicians are burnt out and they're tired. And a lot of what they're tired about is just what we said. I mean, I could tell you that there was a time in my life where I never saw vasa previa, probably because we weren't looking. But now that we're looking, we've got it all the time. And so to tell somebody that even though it's an appropriate indication and we're going to be dinged for it, when we've told people over and over again that we've got these ICD-10 codes, just take them out of the denominator, we sort of feel like we're not being listened to. And I think that we've got enough experience with this measure that we should be refining it. And if we're going to do an electronic measure, this is the time to refine it. And then I think my last point is, and I think that this is going to become even more and more important, is, and it goes back to your comment about you adjusted it up to 30 because you're not adjusting for it, but we've got to adjust for age because the age of people going up is going up. And we know that this is that's a risk factor for cesarean. So I just want to plead for some of these issues that, are getting my tires slashed on a monthly basis.
Sindhu, do you still have your, yes, go ahead.
Thanks. I know this is like a tricky kind of sort of tricky what to put into the exclusions. And I agree, Kim, that, there's all these risk factors for cesarean delivery. And the rub is that when you sort of put in risk factors or, exclusions that way, then you kind of give a pass to doing C-sections that might be unnecessary. And so that's like it's just sort of the continuous rub of this measure of like, what do you exclude? And I think the NTSB is trying to risk adjust. I think what I have one of the more of a problem with, or it's hard, is that things like vasa previa, or where there's nearly like 100%, like that isn't like, there are no vasa previas that don't deliver by C-section. And so the rationale for not excluding certain diagnoses that are always going to be delivered by C-section, especially when a lot of those are referred to certain centers and certain centers will have disproportionately more of them, I think and I think somebody put in, I think Tammy put in, this is about validity. So I'll stop there and just say that I think there's some threats to validity that we need to talk about when we get there. And I'll stop.
Thank you. We've actually already done validity. And, but I think this is an important conversation. I don't want to cut it off too much, but I think we also need to move on. I think these are important, this is important feedback for the developer because there are obviously some strong opinions here and experience. But that said, I think, yes, go ahead.
Sorry, can I jump in really quickly? Just to echo what you said, agree that all these discussions are very important, but for framing for your voting, the specifications discussions should be considered under your reliability vote, and the exclusions would fall under the threats to validity. So that should be a part of your validity vote. We were discussing feasibility, but agree these are important. Just want to make sure you place your conversations with the correct voting.
Yes, thank you. Yes, we are actually discussing feasibility. which I understand is really intertwined in most people's real lives with these validity questions. But I think we should try to stick to feasibility at this point. Is this a feasible measure to collect? And if anybody has any comments on feasibility, now's the time. And if not, Sean, would you show us the voting we're going to be doing?
Yes, of course, just making sure there were no other comments. Thank you, Martha. Okay, for measure 0471E on feasibility, your options are high, moderate, low, and insufficient.
All right, thank you, Sean.
Thank you, Martha.
Let's go on to usability and use. The staff preliminary voting on use was a pass. Could one of our discussants please give us a little background on use?
I think, well, the usability and use was documented to be moderate. It is publicly reported. HAP, CAH, ORYX are all using it as a performance measure. It's aligned with our NQF number 0471. It's correlated highly with the current NTSB endorsed measure at a value of 0.88, the p-value of less than 0.01. I think that in context related to the previous discussion, just pulling it forward, this is a highly actionable endorsed measure. So prior to getting into the details of these exclusion criteria that are desired, we have gross variation in a system that is not working properly. So without even needing to get into those specific exclusion criteria that people want to include, this measure is usable as is. Simple things like pre-cesarean huddles, simple checklists to follow SMFM and ACOG guidelines lead to significant reductions in cesarean. The systems level performance on variation in this measure is horrific. With your factors that are driving this being the hospital you step into, the provider team that you get care from. And so it is highly usable and being used. The minute you take those types of simple, actionable quality processes out, you see rises in cesarean birth. So I'm not sure we need to drill down more. I think that the metric is usable and actionable and received a moderate rating.
Thank you, Diana. Anybody else? And again, I can't see everybody's hands, so if you have your hand up, speak up. Okay, Sean, would you please show us our vote for use, and then just go right into usability if you don't mind. Just show us those two votes, please.
Sure, Martha, thank you. Okay, for measure 0471E, on voting on use, your options are pass or no pass for use.
Sean, is there a separate vote on usability?
There is. I will pull that up one moment.
Okay, great. Thanks.
Thank you so much. For measure 0471E on usability, your options are high, moderate, low, and insufficient on usability for measure 0471E.
All right, Sean, thank you very much.
Thank you, Martha.
Okay, the final vote on this measure is, of course, the overall suitability for endorsement. This is a new measure, and we will be voting yes or no. I guess Sean could show that if you'd like. Go ahead, Sean. I probably should ask for discussion. Is there more discussion on the overall suitability before we show the vote?
So I have one maybe question for the measure developer. And maybe they can point me to this if these data exist in their application. Is there any comparison between hospitals that collected the measure using the sort of chart abstracted version versus the ECQM? Was any analysis done on that front?
Yes, it was, and actually it was published as well. The correlation was 0.88 between the two measures. I can find it in our submission. I believe we did submit that data in one of the submission sections, so I can put that in the chat once I find where you can locate that information.
That'd be helpful, thanks. Because what's going through my head is, in a certain sense, this measure is, you know, it's sort of a newer, not a newer version, but an electronic version of an existing measure, right? So I struggle a little bit because we've endorsed the current version, right? So some of the concerns about, you know, exclusions, risk adjustment, I think are very well founded, but in some ways, if we were willing to pass the measure in its existing form with those limitations, to me, what it's going through my head is this electronic version somehow different in a way that would be concerning?
It's on page 11 of the worksheet that was provided, at the bottom of page 11, and it says it correlated at 0.88, which is strong. The only other concern that I have is that this data is all for 1 year, since this was a pilot. How long have we had the paper collection of data, and does that show a trend in reduction or improvement in the quality of care?
Yes, there has been a reduction, and I believe the chart abstracted version went into effect in 2010. Let me just verify that. Yes, 2010. Okay, good. So yes, we have seen reductions in the chart abstracted measure, and obviously that was all presented. The chart abstracted measure is NQF endorsed, so we do have, we have provided data on the chart abstracted cesarean birth measure for over the years.
It's interesting. This is Elliot Bain again. To make change in this measure, it takes a lot of work and statewide collaboration of multiple partners. We were able to show that in California. It was published in JAMA last year, of a reduction from 26% to 22.7%. Maryland, in a statewide effort, showed a similar percentage drop. Other states, again, with statewide efforts, some have shown success, some have not. And it's generally been related to the amount of organizations that have been involved with the efforts. If it's just one body saying you should reduce it, it generally has less effect. But if there are multiple bodies, payers, purchasers, state departments of health, as well as professional organizations, you can get pretty significant reductions and reduction of outliers, which is my particular interest.
Yeah. Reduction in the mean is one thing. What we are also focused on is reduction in the variation of this, right? So from one hospital to the other hospital, has that reduction been shown with the paper?
We published that in JAMA. There were really three parts to a satisfactory QI project. One is reduction of the mean. The other is narrowing of the bell-shaped curve, i.e. reduction in variation. And third is reduction of outliers. And all that happened in California.
And section 1B03 does have some of that past performance data for our PCO2 chart abstracted that you can look at as well.
I see your hand, Christina. Go ahead.
I feel like I asked Elliot this question in a meeting at some point over the last couple of years talking about the same thing. I don't remember the answer. But in terms of the reduction, is it unique to a specific indication for cesarean? And I guess the reason I asked that is kind of what we're talking about. Is the best goal here to really focus on just all nulliparous patients, or to focus on the reason that is really driving their C-sections? And so rather than NTSV the way it's defined, should we be looking at NTSVs for labor abnormalities or non-reassuring fetal heart rate? And that's also where the MFMU identified the racial and ethnic disparities from a standpoint of, in the lowest risk patients, there were still more C-sections done in Black and Hispanic women for fetal heart rate abnormalities. And so are we, using such a broad category that's not really going to drive the improvements that we're hoping for? Would it be better to hone down the category into what's really driving these C-sections?
Well, it's interesting that the indications of non-reassuring fetal heart rate tracing and labor abnormalities account for the large majority of NTSV C-sections, and they also account for the large majority of the increase in C-sections. The amount of breaches hasn't changed in a generation, et cetera. And they also account for the large proportion of variation among hospitals. So from one A to B, that the difference is not in your breach rate or so forth, it's in your others. It's a little tricky to look at some of the indications, which don't, some people have done C-sections for macrosomia. And does that fall into one of the other categories? And so it ended up being simpler, more direct to be able to do that, recognizing that 75 to 80% of all the NTSV are in those categories, if not more. In response to your earlier question about expanding the exclusions, we are looking at that on a regular basis. We have added placenta previa, for example, which was not in the original set. Vasa previa is easy to add, as well as Secreta, and we're confirming that those would be in, but those would be clear-cut ones. That is what is what Kim was saying earlier. Things that are 100%, you should add in, and that's very reasonable. Things like myomectomy are tough because there's a little myomectomy external versus a major myomectomy. But those don't account for a large number. And again, we're talking about things that affect a large number. If you have, even vasa previas are not very common, even if they're referral centers, they're not going to change your rate from 22 to 30%, for example. I mean, it's just not, that's not the driver. So we are looking at exclusions on a regular basis. And when we re-up the base measure, I think there will be additional exclusions coming up pretty soon.
I just want to reflect on what I feel like I'm observing, which is really smart people from all across the country who probably work in some of the nation's best facilities. And my specialty is working in rural locations. So my research functions on really looking at and working both clinically and academically So the things that it's a natural reaction to feel like your tertiary care center is being poorly rated because you are a referral center. But the truth is that that's the opposite of what's happening. Our tertiary care centers maintain the best cesarean birth rates in the United States. When you look at who ranks the highest, it's often the referral receiving hospitals. So these issues, this measure is working. Actually, it's an outcome measure. The processes that improve outcomes on this outcome measure are super simple. They're checklists, they're team huddles, they're agreeing on evidence-based practice. And in rural America, that's not happening. In urban America, that's not happening. And so when you look at inductions driving cesarean birth rates in the nulliparous population, it's because you can have the research suggesting that we can improve outcomes by inducing everyone. But if you're not following evidence-based practices during the induction, your cesarean rates skyrocket. And that's represented in what was presented to us by the Joint Commission in their measurement portfolio. This measure is working as long as we commit to the processes. It's not failing us yet. We don't need to actually tweak the measure at all until we get to the point in this country where people are guaranteed reliable birth care across geographic settings.
It sounds to me that we actually have more questions about the previous measure, the core measure, than the electronic measure. And what we really need to think about today is whether we want to add this new electronic measure that mirrors the chart abstraction measure for now, realizing that it's not perfect, realizing there may be work to do and modifications, but that we need to move on and decide if we want to endorse this new electronic measure. Any other
Michael, I
comments
agree
on
with
this?
you.
Go ahead.
I agree with you, and I think we do need to move the agenda, but I think that it does become a slippery slope, right? That we keep approving and moving things without refining them. And so I think that that's the point that people are trying to make.
No, I hear that loud and clear. I hear that too. And I think that's all good feedback for the developer who, Chris has her hand up, so go ahead.
Yeah, I just wanted to, reiterate that we do measure maintenance on these. And as Dr. Main said, some of what you brought up may be in the next iteration of the measure. We do receive feedback through our Q&A forum for codes to be added or exclusions or modifications to be made. And we do vet all of those. And we will be, we've held technical advisory panels, and we will be doing that as well. And we review all of our perinatal care measures. So these measures, when we review them with experts, these are the type of things that we've received feedback from you that we will take and, discuss with a larger panel and see if anything should be updated for the next version of the measure. So we appreciate your comments because we do use them and look to always maintain and improve our measures. So thank you.
Are we ready for Sean to show us the vote that we'll be taking? Okay, Sean, will you go ahead?
Thank you, Martha. My pleasure. So for measure 0471E, it is a yes and or no vote on overall suitability for endorsement. And your options are yes or no on overall suitability for endorsement for measure 0471E.
Thank you, Sean.
Thank you, Martha.
I think now we open for public comment. And I'm going to rely on the NQF staff to help moderate this if there are any public comments.
We're actually going to save public comment to the very end. So we'll move to the next two. That's okay.
Okay.
So the next one on our agenda today, and actually I'll provide an intro if that's helpful, because we're moving into the two measures seeking approval for trial use. So Poonam gave you an introduction to this information earlier, but essentially the next two measures do not provide testing for reliability and validity. Presumably this is what the trial use period will allow them to gather to determine that their measure is reliable and valid and can be submitted for full endorsement. There are a number of process items that go along with this that we're happy to answer questions about, but for the purposes of review and evaluation today, the committee will be discussing all the rest of the criteria in order, with essentially the same items being must pass as for other measures, except for scientific acceptability. So we'll start with a discussion on evidence, which is a must pass criterion, and then move to performance gap, which is also must pass. The committee will then take a vote on the specifications of the measure. That relates to the scientific acceptability, but that is the only element of scientific acceptability that you'll discuss and vote on is the measure specifications for actual implementation, and that is also must pass. Following that, there will be a discussion and vote on validity, followed by use and usability. Those items are not must pass. And then the final vote will be whether to approve the measure for trial use, not for endorsement. And a trial use measure, that trial use designation expires after 3 years. So the measure developer is welcome to bring the measure back for a full endorsement review sooner than 3 years. But at 3 years, they either need to submit for full endorsement or determine that something didn't work about the measure's implementation, and then that status is lost and it is not endorsed. Before I jump in, are there any questions about this? Okay, great. So the first, well, let me check on your behalf, Kim, if the measure developers are on the line today from the University of California, San Francisco.
We are.
Great. Then I will turn it over to Kim to start with 3682E.
So this is a measure I like the self, but I can't, I don't have it in front of me. So we'll let the measure developer tell you what the an acronym stands for, but it is the percentage of women who received or had documented use of most or moderately effective contraception during the postpartum period, which is the primary measure, and then received a long-acting reversible contraceptive method during the postpartum period, which is a sub-measure. And to focus the measure on the population of women interested in contraceptive services, the denominator excludes those individuals who did not receive or have documented use of a method if they had indicated they did not want these services. So that's where the self comes in, that these are people who want to be on contraception. So with that introduction, it is a facility level measure in the outpatient setting, and it is designed to be an electronic health record. There are no recusals, and I will now turn it over to Christine from UCSF.
Thank you so much, Dr. Gregory. It's a pleasure to be here. So I'm Christine Dellendorf. I'm a family physician and reproductive health researcher at the University of California, San Francisco, and director of the Person-Centered Reproductive Health Program. I'm here with my colleagues from our team, Rebecca Kriz, Lindsay Gibson, and Sonia Goch Avila, as well as our colleagues from Far Harbor who provide support for our measurement work, Dr. Fei Dong and Ella Puga. So I'm going to take some time just to provide some introduction to both of these measures since they are very related, and then I'm happy to revisit the non-postpartum measure when we get to that. So we are applying, as was stated, for these measures for approval for trial use. One of these measures, the one we're currently considering, is for the context of postpartum care, and the other is for the non-peripartum context. So our team at the Person-Centered Reproductive Health Program, in collaboration with Far Harbor, has developed these measures with support from the Office of Population Affairs, which is the federal agency that conducts research and support and services around family planning in the Department of Health and Human Services. And we have two staff members from the Office of Population Affairs, Roshni Menon and Jamie Kim, here with us today. So thank you both for being here. So these measures and the support from these measures from the Office of Population Affairs is part of their ongoing effort to develop a robust set of measures that can be used to promote access to quality patient-centered contraceptive services in the United States. While it has always been important to prioritize quality improvement in this area of care, given that almost all women at some point in their lives seek out pregnancy prevention services, and the fact that there are documented gaps in quality and access to these services, it is all the more important currently, given our evolving policy environment for reproductive health and threats to reproductive autonomy. The goal of these specific measures that you're considering today is to provide a novel approach to assessing the extent to which facilities meet patients' needs for contraception. Through leveraging electronic health records, these measures are able to be used in a broad range of clinical care contexts, including those that rely on prospective payment systems and therefore can't use claims data to measure contraceptive provision and care. This is particularly critical given the fact that there's an increasing importance of primary care settings in contraceptive care, including federally qualified health centers, which use prospective payment systems. In addition, use of electronic health data allows the measure to be both more nuanced and patient-centered, including making it possible to document both use and provision of contraceptive methods as opposed to provision alone, since it can take into account long-acting methods that have been provided prior to the current measurement year. In addition, electronic health data makes it possible to exclude those individuals, as Dr. Gregory mentioned, who do not desire contraception from the measure. To accomplish the goal of being able to have these people be excluded from the measure, we at the Person-Centered Reproductive Health Program created the Self-Identified Need for Contraception, or SINC screening question. That's the acronym Dr. Gregory was referring to. And we developed this in collaboration with reproductive justice consultants and stakeholders in the field, and we're guided in this process by research on how patients wish to be asked about their reproductive health needs. This novel data element helps guard against the possibility of directive or coercive counseling towards contraception that may be the unintentional result of the use of a contraceptive use performance measure. This is particularly important given the ongoing history of reproductive oppression, contraceptive coercion, and biased counseling in the United States directed at women of color and low-income women. A standardized measure of self-identified contraceptive need also provides an opportunity to hardwire patient-centered workflows into the electronic health record that can facilitate patients having their needs met. So over the past few years, we've been working collaboratively with stakeholders, including the National Family Planning and Reproductive Health Association, or NIFRA, the Coalition to Expand Contraceptive Access, or CICA, the National Association of Community Health Centers, or NAC, and health center controlled networks and community health centers themselves to develop the specifications for the measures being considered today. We considered this in-depth engagement prior to data collection for validation of these measures to be essential to ensure these measures are optimized and acceptable to future users. We are now in the process of launching a year-long data collection project, the Innovating Contraceptive Care in Community Health Centers project, which will provide the data to allow for the validity and reliability testing of the measures, which is necessary for full endorsement, and will also allow us to collect information about how to optimize implementation, use, and interpretation of these measures. We anticipate we'll be able to submit an application for full endorsement to NQF within the next 2 years, which will bring us under the deadline of 3 years that was referenced earlier. Ultimately, our hope is that these measures, together with the previously endorsed contraceptive performance measures, will contribute to our ability to ensure that patients receive high-quality, patient-centered contraceptive care as they navigate their reproductive lives. Thank you for your consideration of these measures, and we look forward to the discussion.
Thank you very much. Matt, you're our lead discussant.
Thanks so much, Kim. So I guess we're going to start with evidence. Is that where you would like to start?
Yes.
Okay, that'd be great. So what I personally noted about the evidence that the measure developer provided is they did note a number of existing clinical guidelines support evidence for this work. What I would also note is that this evidence mirrors the evidence that is used for measure 2902, which is the sort of original version of this measure. And it's a measure that this committee has reviewed and has endorsed for endorsement. So I guess my assessment is that the evidence is strong and mirrors other evidence we have reviewed.
So there are no additional reviewers, but I will open it up to the committee for comments. Feedback. Okay, do we have a quorum or we're still?
It looks like Jennifer.
We don't, but I see Jennifer's hand.
I think my hand is blending in with my wall color here. So I really like the concept of a contraceptive measure that accounts for people's choices. I am also concerned, and I'm in the heart of Ohio, that we are keeping databases on every woman who comes into us who may be getting IUDs, other kinds of things, her preferences, and that this may be used against her in some way. I am concerned that this data will be subpoenaed. I don't mean to sound paranoid, except for, as we all know, things have been changing quickly lately. I am concerned about large-scale measures that measure IUD use potentially being out there. I don't know where that fits in here. It's not validity, it's not reliability. It's sort of more macro, which is why I mention it here and now. Obviously I have no evidence that this will be used this way, but I think we need to be very cautious. It's one thing to study this in California. It's another to have it in the heartland.
I have my hand up. I don't know if you can see it.
Thank you for speaking up, Sheila, please.
Okay, yeah, I just have a quick question, and I totally agree with what has been said. I just have a methodology question. In terms of the standardization of how the question was asked, the context that the question was asked, and even the age of the woman, because it may be different in one age group, in an older age group, than in a younger age group. Can you address any of those?
So in terms of the question about the question and any differences in age, and I would argue other aspects of the clinical care context, our goal with developing the measure, developing the question, the sync question, was to provide for adequate specification to avoid harm in terms of reproducing this any messaging around what people should be doing with respect to their reproductive choices in their reproductive lives, while also continuing to allow for flexibility in specific care contexts and with specific patients. So that is included in our implementation guidance. And while we think this is something that is a question in general that can be applicable across age groups, across reproductive histories, it is something that can be adapted to specific contexts, and that is explicitly included in the implementation guidance.
Okay.
I appreciate the comment about concerns about use of the measures. I certainly understand and feel that the evolving policy context and legal context is obviously part of the landscape that this measure is being proposed within. I think the fact that we're in a trial use period will allow us to get more information as the policy environment continues to evolve and understand this prior to planning for widespread implementation.
One more question. Did you say this, the data is self-reported?
So the self-identified need for contraception data element is something that is included in the electronic health record, but is asked of the patient to be documented in the healthcare record, similarly to things like the PHQ-2 or history of falls, which are documented within the health record as electronic data elements, but are patient-reported outcome measures.
Okay, thank you.
Any other questions? Okay, so I think that we can, I see, Martha, please go ahead.
I think just looking at the evidence that it's clear there are gaps and a need for assessing the individual's need for contraception, self-identified need for contraception, and then whether they're getting, basically getting what they want. You know, whether it's a long-acting reversible, a LARC, or whatever they prefer. So I think there's clear evidence that this measure is important, and I'm personally, you know, of the opinion that we need to be moving all these measures to electronic. And the EHR developers are not going to include a measure, and not going to include a data element until there's some expectation or requirement that it's there. And so we'll get that in terms of incorporating that sync measure into EHRs, because it's not there now. But I think on the strength of evidence and the performance gap, there's clearly a need.
Okay, any other comments? I'm gonna flip my screen to make sure I don't miss anyone. Okay, then I think we are prepared to vote on the importance of the measure, and we must pass for this. So we're voting on the evidence. Thank you, Sean. I'll let you take over.
Thank you, Kim. No worries at all. For measure 3682E, importance to measure and report 1A evidence, your options are high, moderate, low, and insufficient. And NQF staff preliminary rating for evidence was high.
Oops. Matt, do you want to comment on scientific, oh, I'm sorry, and then is there a vote on the performance gap? And again, it would be high, moderate, low, or insufficient.
See a question from Christina Davidson.
Yes, please, Christina.
I'm so sorry if this was already discussed. I had to step away for a minute, but does this factor into a patient wanting that contraception, but not being able to get it because of her insurance type?
So I think that is a critical question that is totally valuable to think about. Again, the policy context being what it is. I think that what the reality is, this is being measured at the facility level, right? And so individual facilities would be responsible for thinking about how to provide some method of contraception. It doesn't have to be, you know, necessarily the full range of contraceptive methods to their patients who want to use them.
I'm thinking specifically, I work in Texas and at a safety net hospital where CHIP perinatal doesn't cover contraception, period. And so no matter what the patient wants, it's a little bit tricky. And so like, how do we account for something like that?
Right. I think that would obviously be a contextual factor that would have to be taken into account when interpreting the measure. And again, we will be, you know, we're doing the pilot in a broad range of contexts, and we'll be looking at that. I think that we need to be capturing if that's what's happening, we should be capturing it. And that provides the data to encourage policy change in the direction of fixing the problem that we need the data to point out.
I absolutely agree with that. So then I guess my recommendation would be, if we weren't already planning on it, is looking at this by payer type.
Right. Thank you.
So Tammy, it looks like Kim is on a call. I don't know if.
Are we ready to go ahead and look at the vote on performance gap? Oh,
Sorry, I'm on call. Yeah. So we were going to vote on the performance gap. Did we vote already?
Okay, for measure 3682E, importance to measure and report performance gap, your options are high, moderate, low, and insufficient. And NQF staff preliminary rating was moderate for performance gap.
And just a clarifying question, because I think I'm confused. Are we actually voting, or we're just?
No, there should be no voting live on the call. We will be sending an offline voting survey since we lost quorum this morning, just aiding folks for writing down their choices.
Thank you.
Thank you, Matt.
And then Kim, before we jump forward, I just wanted to make sure that we did discuss gap separately. So evidence, is a separate discussion. I know there was some discussion about gap in that, but we, should make sure that we're talking about gap separately. Matt, sorry if I missed it. Were you able to provide a quick summary on gap at its current level?
So the only note I had was that the measure developer did note that there's variation in performance in the use of contraception across different practices and women of different subgroups. So at least my assessment was that we do see a gap in performance and that we do see disparities and variation.
Okay. I think we're good. We're going to go to scientific acceptability. Matt, would you like to share?
Yeah, so I guess a question, I guess, for NQF staff, because this is not a required vote, because it's a trial use measure, are we going to talk about scientific acceptability?
They want to talk about the specifications.
Oh, that's right. Okay. So I was not well prepared for that. So I'll do the best I can on the fly, but welcome obviously additional thoughts from the rest of the committee members. The only thing that was noted was that is that a code will need to be added for the self-identified need for contraception to electronic health records that are currently in use. So I guess it's the capture of that data field, but I didn't see anything noted about the
Chris, can you help us?
Sort of the about the sort of what's the word I'm looking for? Yeah, the sort of the clearness of the measure specifications.
Is there anyone from the measurement development team that can help?
Well, I'm happy just to provide a broad overview, which is that we convened, as described in our application, we convened multiple expert work groups to optimize the specifications while minimizing burden in terms of calculation. And that included paying attention in the context of this postpartum measure to details around if the live birth date is not available, integrating an estimated delivery date as an option for the start point for the 90 days in which postpartum care should be provided using the revised ACOG guidance for postpartum contraceptive care in the postpartum period. We also integrated considerations for if preterm birth were to occur, how that could be incorporated into this measure as well in a way that did not penalize people by not including contraceptive methods that were provided prior to the delivery date if people were in fact to deliver early, but no live birth date had been documented. So we made every effort to ensure that this is as accurate as possible in terms of capturing postpartum contraceptive care delivery within the limitations of the data available.
Comments, questions? Martha?
This is a question that I think will show up a couple times as it goes to feasibility and usability. But my big question was, have you as the developer, including our developers, to understand that their willingness to add this measure, or maybe it's not the EHR developers, but it's the set of codes. It has to be added to different coding sets, right? And then the EHR developers have to incorporate those into
Yes.
their EHRs, something like that. So have you had those conversations to see how feasible that really is? Are they willing to do it? And again, you know, having a requirement to report a measure may help move that. But so give us a sense of that feasibility, I guess, and how you're going to do that.
Yes, thank you for that question. So we have included the sync measure in standard nomenclatures within EHR, specifically the LOINC system, and are looking to integrate it into the SNOMED system as well. So that is absolutely an essential first step into doing this. And then we have been in ongoing conversations, specifically with health center controlled networks, which are groups that receive support from the Bureau of Primary Care to support the EHRs of federally qualified health centers. In addition to, they also provide services for other health systems as well. And so they have instances of different health EHRs that they oversee for broad networks. And so we have been in conversation with them about how this can be integrated into their network specifically. And what we have found is that it varies, not surprising, by the type of EHR, right? So for example, we are working with one large health center controlled network called OCHIN, who was able to integrate this into their instance of Epic in the rooming tab and turn it on for all of their users instantly. Whether or not it was being integrated into clinical workflows is obviously a different thing, but they could integrate it, and it has been integrated for all of OCHIN. In contrast, we are working with another health center controlled network called Health Efficient, which uses a different electronic health record. In that case, each health center itself has to turn it on in their own system because they have local editing power. So that is, just there is a range of different ways that this has happened that are enabled by it being part of the standardized nomenclature systems like LOINC that I described. And so we are going to continue to work on this process as we move forward. But we feel, given our experience to date with a variety of different health records, it is clear that it is possible if the will is there, as Martha, you already referred to.
Thank you. I would expect that OCHA would be able to handle that, and I'm familiar with large network. But some other EHR
Tammy?
Aren't.
We can't hear you. Tammy?
Sorry, I think Martha was speaking, but I think she's breaking up a little bit. I just wanted to jump in because we're a little bit into feasibility, and I know that line is very gray with specifications. So just kind of as a nudge, what NQF review of the specifications found that the technical specs for ECQMs were not hindered by limitations in any of the technical specs, the data gathering, and then that the ECQM was specified using the latest industry accepted ECQM technical specs, which I think the developer spoke to as well, but just want to separate specifications from feasibility.
Great. Any other comments or suggestions from the committee? Then I guess we will move to scientific acceptability. And I will turn it over to Sean.
Thank you, Kim. One second. Okay, so for measure 3682E, scientific acceptability specifications, your options are high, moderate, low, or insufficient.
Okay, since we don't have to wait to see if your poll came through, we can now go to feasibility. Matt, any comments on feasibility? I will note that the staff preliminary rating was moderate.
Yeah, so I may have misinterpreted, or maybe I'm giving myself limits. So there's a table within the documentation that seems to indicate that there's certain data elements for which there might be feasibility concerns. And in the far right-hand column, the measure developer responds with how they would address the concerns for that data element. Most of them seem to speak to this idea of different EHR systems using multiple combinations of code systems. And that this ECQM includes several terminologies that facilitate the measure use and calculation, and that they plan to collect similar data using other codes. I guess for me, lacking, just knowledge, I don't know what that means. So I'm hoping at some point the measure developer could sort of address what that is so that I can better understand whether or not feasibility is a concern, or if this is what concerns me with all these electronic clinical quality measures is just how do we sort of move towards standardized data feeds? And if we don't have those, how are we sure that these are feasible and reliable and all that stuff? So that's my overarching comment, which is more of a question, I guess.
Yes, thank you very much for that. And it is definitely, it is definitely a challenge, both to describe and to understand. So essentially what I would think about this is redundancies, right? So different electronic health records are going to collect different pieces of information in different ways, right? But if someone prescribes a medicine, like oral contraceptive pills, or document that someone is using oral contraceptive pills, it's going to be captured in some way in the electronic health record. So the goal of our measure is to build in redundancies so that whatever the system is that's used, we capture that. So if it's because they actually put in an ICD-10 code about, prescription of contraceptive care, contraceptive pills versus a RX norm code, which is actually, the standardized EHR nomenclature for provision of certain methods. Even if they don't use RX norms, we can capture it through the ICD-10, just as an example. Ideally, they're using the RX norm because that's what we're moving towards in terms of standardized nomenclature in EHRs, but recognizing that that's not universal and that the variety and the extent to which, a range in which different systems, vendors, et cetera, are using these standardized nomenclatures, we basically built in fail-safe so that we could capture it across the different ways that these pieces of information are being created. So yes, that table was incredibly redundant, and I hope that you didn't read it every single cell because it was, repetitive. But the point of this was that maybe you don't use RX norm at all, and you don't use SNOMED at all, but we will capture that same information using other coding systems that are built in to capture that information in different settings.
That's helpful, thank you. Does that create an opportunity for conflicting information, right? That you collect the same variable from two different ways that conflict with each other? And if so, how do you resolve those conflicts?
I think we'll get more information as we move forward with the data collection process in our current project. And given that it's basically provision and use or not, any provision or use documented in any coding system will count as use, right? So even if it's not capturing the exact same data, if they capture anything in any of the terminologies or systems, then that counts as having provided contraception. So most of these are binary yes/no questions, and a yes counts for the entire year. So for example, if sync is asked multiple times in a year and they say they don't want it sometimes, but they say they do want it once, then it counts as a yes. So it's not as much conflicting information, but aggregate information over the course of the year that will allow us across the different systems and nomenclatures will allow us to calculate the measure.
So one quick follow-up, which is you mentioned that if the record shows yes for sync, then it will count yes for the year. What happens if the woman changed her mind during the year and was making a different decision at a different point in time?
Right. So she said yes at one point. So she should have received contraceptive care at that point, right? But that doesn't mean she needs to have gotten contraceptive care the entire year, right? So then she comes back later, or she comes back before. She didn't want it. She wouldn't have gotten it during that time.
Okay.
At some point in the year, she wanted contraceptive care.
Okay. And at that time, she should have been provided it. Okay.
Right. Exactly.
Okay. Okay. Thank you for that explanation.
Any other questions from the committee? Point of clarifications? Okay, then we are voting on feasibility. Sean?
Thank you, Kim. So for measure 3682E on feasibility, your options are high, moderate, low, and insufficient. And NQF staff preliminary rating was moderate.
Okay, Matt, we're going to move on to usability and use.
So my understanding is that we'll tackle use first. But this measure is planned for an accountability program. It won't be publicly reported, and it isn't currently used in an accountability program. I guess the one question or concern that I had around use was one of the criteria or feedback that we're supposed to be evaluating the measure on is whether those who are being measured will be informed about their performance. And it was not clear to me how that is or will be happening.
Apologies that was not clear. We absolutely do plan to provide summary measure reports to the participants in our ICC project, Innovating Contraceptive Care project. And through that process, we'll be able to obtain more information about how to optimize this reporting and to be able to summarize that ultimately at the end of this project in guidance for reporting and aggregation of the results.
Okay, thank you. And one thing to add, which probably Sean would have added it anyways, the preliminary rating by the staff was a pass on this, on a pass, no pass.
Any other comments from our committee? And if not, we'll move to voting.
I've got a comment, if you can hear me. I actually really appreciate the work that's been done on this. I think it may be a heavy lift, but the only way to do that is to do it. So I wish you a good. I hope it goes well, and that you come up with a usable measure out of it.
Thank you so much.
Sean?
Thank you, Kim. So for measure 3682E on use, it is a pass or no pass vote. Therefore, your options are pass or no pass.
And finally, Matt, with regard to usability. Oh, no, not final, but.
Yeah, the measure is being submitted for trial use, so it's not in use yet. Therefore, they aren't able to necessarily document any improvement results that they've seen with this measure. They have not reported any unexpected findings, once again, because the measure is not yet in use. There's not any anticipated unintended consequences. And similar to the previously endorsed contraception use measures that this committee has reviewed, I think there is an overarching concern around whether women are being being led into making a decision about contraceptive care and are free from pressure. And so they did incorporate the sync question into it. So I think that is an addition to the measure that we didn't see in the chart abstracted version that I think starts to address that concern about coercion and pressure. So that's sort of a summary, and what others noted was no concerns with usability. And the staff rated it a moderate.
Any other comments from the group? All right, Sean.
Thank you, Kim. So for measure 3682E on usability, your options are high, moderate, low, and insufficient.
All right, now we get to the last measure, Matt, and that is, unless I guess if anyone on the committee has any other comments in regard to the approval for trial use. Does anyone want to say anything, or the NQF committee want to give any advice in this particular situation?
This is Tammy from NQF. I have nothing to add unless anyone has questions, but Kim's leading you in the right direction, so.
All right, well, then we will vote to whether or not it should move forward with a vote for trial use. Sean?
Thank you, Kim. So for measure 3682E, approval for trial use, does the measure meet NQF criteria for approval for trial use? Your options are yes or no.
Okay, I think that means I turn it over now to my co-chair, who will go through a similar process with us.
Yes, and please start waving at me or something if I'm breaking up. I think to be expeditious here, that we really want to focus our thoughts on any differences in this measure, which is a non-postpartum measure, compared to the previous measure, which is the same, essentially the same measure for postpartum women. I think the description is the same. It's also at the facility level, it's outpatient care, and it's EHR data. So, Christine, do you have anything to highlight for us in terms of the differences between this measure and what we've just finished discussing?
I would just say that this is designed to measure a distinct care pathway, that the postpartum care is designed to measure the peripartum care pathway. And this is a separate, completely separate, non-overlapping population of people who are not receiving postpartum care during the measurement period and would therefore fall into this non-postpartum care measure. So our idea was to facilitate quality improvement at a facility level by providing feedback on quality of care in these two different care pathways, the peripartum and the non-peripartum contraceptive care contexts.
Great. Matt, it looks like you're our lead and only discussant. Will you highlight anything that we should pay attention to that's different, perhaps, in this measure from the previous one?
Yeah, so my comments are going to be very similar to the last one, so I won't spend a lot of time repeating things. The only thing I'll make note about the evidence is the evidence for this measure is similar to the evidence that was presented for measure 2903, which is a currently endorsed measure, also reviewed by this committee. And the developer noted a number of existing clinical guidelines that support evidence for this measure. And that's about all I have to say.
Okay, any questions from the committee on the evidence for this measure? Okay, then we will, on our own, vote for this, vote on this measure on the basis of the strength of the evidence. And Sean, if you would show us that question one more time, please.
I would be happy to, Martha. Thank you. So for measure 3699E, importance to measure and report on evidence, your options are high, moderate, low, and insufficient.
Thank you, Sean. And I will note that the staff gave this a preliminary rating of high on the evidence. Okay, we move on to the performance gap. Sean, anything there?
So this is Matt. The only thing I'll note is
I'm sorry, Matt.
That's fine. That's fine.
Got my faces.
You were talking about me, so I decided to answer. The measure developer did provide some data indicating gaps in performance today about contraceptive care, showing that only 15.9% of clients age 15 to 19 and 17.2% of clients age 20 to 44 were provided with a LARC method. And they also did share some data from the Washington State Healthcare Authority, suggesting that there's opportunities for improvement across different race and ethnic non-postpartum groups in terms of access to a full range of contraceptive methods. Although they did not necessarily, it looked like, provide a specific distribution on that, but there were notes of that. The staff did give this an overall rating of moderate. And so my assessment is that there is variation in performance in use of contraception across different subgroups, and so that there are opportunities to see some improvements.
Thanks, Matt. Questions or comments from the committee? Okay, Sean, now I've got the name right. If you would show us the vote on performance gap, please.
My pleasure, Martha. Thank you. For measure 3699E, importance to measure and report on performance gap, your options are high, moderate, low, and insufficient.
Okay, thank you. So we move on to scientific acceptability. Again, Matt, I'll turn that over to you.
Yeah, so my understanding is, once again here, all we're really evaluating is the specifications for the measure and whether we think those are reliable. What's interesting is I have a note that I'm going to try to follow up on myself before the time runs out, but I have a note something about Site 2 and having missing data, and how that issue would be resolved for all sites moving forward. But I don't really remember what that missing data was, so I won't necessarily put the developer on the spot to answer that now, unless that's clear to them what that means.
I think it was the same issue we talked about before, that they didn't have RX norm, but they had others. It was the redundancies. So some of the coding systems were missing, but we built in the redundancies for that reason.
Okay.
And it might have been presented, I think it was presented a little bit differently to you in summary in the two different measures. So it probably seemed a little, it didn't seem the same, but it is the same issue.
Okay.
That's my guess.
Yeah, so like I said, I'll look at that before the call is over. So I don't see if the staff gave any sort of preliminary rating for this, for the measure specifications, but that's about all I have to say on it. Because once again, I was sort of caught off guard that we were even doing this part of the evaluation. So
All right.
I'm underprepared.
You're doing just fine, Matt. Thank you. Does anybody have questions or comments on the scientific acceptability, specifically the specifications? Nope. All right. Could we get a quick view on that vote, please?
We can. So for measure 3699E on scientific acceptability, vote on specifications. Your options are high, moderate, low, and insufficient.
Okay, thank you. We move on to feasibility. The staff rated the feasibility as moderate. Matt, what else do we need to know?
The items seem to be similar to the previous measure, which is the measure developer identified a number of elements for which there were feasibility concerns, and they laid out a plan for addressing them, and it appears to be sort of a similar plan in terms of creating redundancy in those data elements.
That and adding that entirely new data element for the self-identified need for contraception, the sync, but that will be the same for both measures. Comments or questions from the committee? All right, John, will you show us that vote, please?
I will, Martha, thank you. So for measure 3699E, vote on feasibility. Your options are high, moderate, low, and insufficient.
Okay, there are two sections, one on use and one on usability. You want to do use first, Matt?
Sure. So similar to the previous measure that we reviewed, my only comment was really focused around how to inform those who are actually being measured. I guess I will ask the measure developer to see if the plan for doing that is the same as the previous measure. I guess I was going with that assumption, but maybe that's not a fair assumption.
This is a collaborative, right? Basically with the community health centers, because they, FQHCs bill on a prospective payment system, they may not necessarily be capturing some of these codes right now. So this is a QA project to kind of geared toward health centers. Is it, if I'm getting that right? Yeah.
Correct.
And so
Yes.
and it's really a very collaborative, usually with the health centers, it's a very collaborative development process, testing, and reporting results, improving results. It's usually very intensely collaborative. And I would expect that's what you're working on here. Yeah, okay.
Correct. The other thing I'll note real quick is I did note that the measure developer for this measure in particular indicated that the data aren't publicly reported. They're not used, they're currently used in an accountability program, and they're not planned to be used in an accountability program. So I don't know if for trial use that becomes a deal breaker, but I would think by the time we get to an endorsement that there does need to be more of a clear plan for the measure's use. So, and maybe a question for Tammy, which is, if for trial use, does there need to be a plan for use, or is that more of an endorsement criterion?
For trial use, the use that they're doing during the trial is not really like an accountability or benchmarking program. So that would come into play for an endorsement review, more specifically about whether there's going to be a public reporting of it at that point in time.
I'd like to add, just because I know the health center world pretty well, that I think that Christine, this was in the development or in the materials that were presented, although it was kind of fine print. The community health centers report to HRSA, the Health Resources and Services Administration, on an annual basis a fixed set of quality metrics. And so I think that I read that their hope, and of course it's probably an ongoing negotiation with HRSA and the Bureau of Primary Health Care, but their hope is to get this measure included in the standard set of measures that the health centers report. And just for context, the health centers provide care for 20 million or so people in the United States every year. And so it would be publicly reported, but perhaps in a subgroup of facility types that are federally supported. And Christine, if I got that wrong, please correct me or add to it.
Sorry, I was muted. No, that's exactly right. Thank you for that description. Absolutely. And also, you know, in addition, we're looking with Office of Population Affairs and the Title X program as well as another example as well.
Yeah, I forgot you said that. The Title X programs, the family planning programs, assuming we still have family planning programs, yes, would be perhaps another set of facilities that would report this measure. But I understand that's probably an ongoing negotiation.
Yes.
So that was a long conversation. Are we still in use? Yes, we're still in use. Any other questions or comments? All right, Sean, will you show us that vote, please?
Sean, Martha, thank you. So for measure 3699E on use, this is a pass or no pass vote. Therefore, your options are pass or no pass.
Great, thank you.
Great,
All
thank
right.
you. All right.
Now we're down to
Now we're down to
usability.
usability.
And now I've got an echo.
Now I've got an echo.
Matt,
Yep.
anything else to report here?
Yeah, nothing different than the other measure. The measure developer does not anticipate any unintended consequences of this measure. Addition of the sync variable should reduce the coercion and pressure that women could potentially face in terms of their contraceptive choices. So comments carry over from the previous one.
Great. Any questions or comments from the committee here? Okay, Sean, show us our vote, please.
Sounds like a plan. For measure 3699E on usability, your options are high, moderate, low, and insufficient.
All right, so the final vote that we will take is whether we vote to approve this measure for trial use. And that's a yes or no vote. Questions or comments in general about this measure or about any concerns you have about approving it for trial use? You're a quiet bunch. No talkers? Okay, Sean, show us this last one, please.
Thank you, Martha. So for measure 3699E, the vote on approving 3699E for trial use, it is a yes or no vote. Therefore, your options are yes or no.
All right, I think that ends our discussion on this trial measure. And I'm going to turn it back over to Tammy to discuss related and competing measures, I think.
Thank you, Martha, and thank you for everyone for bearing with us today with losing quorum. I know this isn't an ideal way to conduct a meeting, but we really appreciate all the participation and discussion in today's meeting regardless. We actually won't be holding the related competing discussion because they only do that for measures recommended for endorsement, and we don't have those votes yet. So we will hold on that discussion until the post-comment call. As a result, we will now move to our NQF member and public comment period. So I'll invite anyone on the line who is an NQF member or a member of the public. If you have something you would like to comment on, to please take yourself off mute and make your comment. You can also put your hand up and someone from the team will call on you, or you may put a comment in the chat and we can read it out loud for you. I'm not seeing any hands or comments, but we'll wait about 30 more seconds. If any NQF members or members of the public would like to make a comment now, please do so. Okay, hearing nothing, I will close the line for comment and I will turn things to Sean to talk about timelines and next steps.
Thank you, Tammy, so much. So just as a brief overview of some upcoming next steps, following this meeting, NQF staff will compile an offline voting survey for the standing committee members to submit their votes, since we did lose quorum for live voting today. And there will be a recording made available to assist standing committee members with their votes. Following the compilation of all votes, NQF staff will prepare a draft report detailing the committee's discussion and measure recommendations. This draft report will be made available for a 30-day public and member commenting period. Following this 30-day public and member commenting period, NQF staff will compile all comments received during this period into a comment table, which is shared with developers and standing committee members. Following this, the standing committee will reconvene for a post-comment call later this year at a date to be determined to discuss any relative comments submitted around the measures this cycle. NQF staff will incorporate these comments and committee responses to comments into the draft report ahead of the Consensus Standards Approval Committee meeting, which is another NQF convened body that meets to endorse measures under review each cycle. Following the CSAC meeting, there is an opportunity for the public to appeal any endorsement decision that follows out of this call. As a result, since we did not conduct live voting today, we will be canceling our backup date for July 8th, this Friday from 10 to 1. So everyone be on the lookout for that cancellation in your calendars. The draft report commenting period will run from August 15th through September 13th. And we will be scheduling the post-comment call at a later date to be determined for sometime this fall. And the CSAC review and appeals period dates will be made available shortly as well, following the post-comment call once that is determined. As always, you can please feel free to contact our project team at perinatal@qualityforum.org. You can also find relevant resources on our project page, as well as measurement materials and further details on our SharePoint site. Does anybody have any questions today?
Sean, when can we expect to see the information and the voting?
Great question, Martha.
Link, whatever.
Great question, Martha. So we will make that available within 48 hours. We will send out the meeting recording as well as the offline voting for SurveyMonkey, and we will make that available within 48 hours. So be on the lookout for that as well. Thank you.
And what kind of turnaround are you looking for?
We give committee members 48 hours to complete that survey as well.
That said, we do need to receive a quorum of votes. So if we do not have enough votes after 48 hours, we will extend that time period and we'll start sending specific emails to those we haven't heard from to nudge them to listen to the recording and submit their votes.
So then, does that mean that the full committee is eligible since it's going to be a recording, all 22 and not just the 15 who were supposed to be here?
Yes, exactly. And that's why we send the full recording. So anyone who listens to the committee discussion and is prepared to vote can do so and can vote on the measures. And that's why we don't collect the votes at this point either, so that the full committee has that opportunity. But we will close voting once we receive a quorum of votes after that time period. So we will attempt to get this done. Like Sean said, we aim for about a 48-hour turnaround. So we'd like to get it to you before the weekend because that's 48 business days. So that would give actually closer to 4 or 5 days, depending on when we send it. But we'll definitely be clearly communicating about timelines and what the needs are to wrap up this cycle so that the committee knows what's lacking or what the delays are.
Right. My point of clarification is, what is a quorum? Is the quorum 22 or the quorum is the 15 from today?
The quorum is actually always based on the total committee members. So the 15 quorum number today is based on the full committee. So as long as we receive 15 votes, we have a quorum. Yep.
Thank you.
Hearing no further questions, I will now hand it back over to Tammy for some closing remarks. Thank you all so much.
Thanks, Sean. And just another thanks to everyone for joining us. And really, we know that people manage their schedules to be here from various places in the country and the world and around flights and travel and internet, Wi-Fi issues and everything. So we really appreciate your presence and your participation. And we thank you for your commitment to this committee and to the work that you're doing here. Thank you to our developers also for being on the line today and for working through these numbers issues with us. And we'll keep you posted as to the outcome of your measures as well, of course. And then another thank you to our lead discussants for jumping in to help lead us through these conversations today. And a big thanks and a round of applause for our co-chairs, also in less than perfect conditions. I'm sure they're both tired and ready to sign off the call. So thank you for leading us through this today. I'll turn it over to you for any closing remarks. Martha?
Well, thank you everybody for the really interesting conversation, very thoughtful. I think we provided some good feedback to the measure developers, and I think we're doing a good job moving things along. So I appreciate everybody's input and attention. I wish we'd been able to vote, and maybe NQF can reconsider this their stand on not being able to vote once we've lost a quorum, but that's for another time. And I'm really grateful for everybody's participation today.
And I'll just echo, thank you everybody, specifically Matt and Sindhu for reading those 70-page reports. There's actually really good information in there, which is why we do have a primary discussant to bring out things that may not ordinarily come up. And I appreciate everyone who asked questions and the work of the developers, and hopefully we'll have some answers for you soon. Until we meet again.
Thanks so much, everyone. Have a good rest of your afternoon.
Bye-bye.